Dr. Shaista, who is moderating today's sessions?
Professor Gaurav will moderate from our side.
Okay. Let me make him host.
Hello, Dr. Nurul, I am here.
Yes, sir.
How are you?
Yeah, fine. Sir,
Ah.
would you able to recognize me?
Yes, definitely. Why not?
Yes. It's a long time, we
Yes.
are face to face virtually though.
Last time when I saw you, your hairs were black. Now they are little gray side.
Sure. Good.
So we can start the session now. It's time.
It's yes, so at least 1 minute away from the scheduled time, and we have made this live on YouTube as well.
Okay.
So,
Sir, Principal Sir has joined. So good morning, sir.
Good morning. Good morning. Nice to see you. On this.
Sir, same here, sir.
Good morning, Dr. Tiwari.
Good morning. Very good morning. Very good morning.
Gaurav sir, please
Yeah.
start the meeting.
Okay. Very good morning to all of you. So I am let me introduce myself. I am Dr. Gaurav Singh, professor in the Department of Prosthodontics, Dr. ZADC, Dental College, AMU. So as we know, like already we have completed 3 days of this course. So today is the 4th day, and today's session is mainly focused towards the management of orofacial pain. Till now, we have covered the different aspects of orofacial pain, like types of pain, their pathophysiology, diagnosis part. And so today's session is mainly for the management of pain. So we have first lecture, the management of orofacial pain, and Professor Yoshio Matsuka is our first speaker for today's session. So I request Professor Matsuka to take over the guys.
All right. Thank you, Professor Gaurav.
Yes, sir. You're welcome, sir.
So I will present my. I will start my presentation. Can you see my slides? Yes.
Yes, sir.
Thank you. All right. So today I will talk about the management of orofacial pain, and the picture is the Tokushima Prefecture rural town. We have this is a rice field. All right. So tips for coping with pain for patients. This is for patients. So we can say stay active. Pain can lead people to stop doing the things they enjoy. It's important. Oops, sorry. It's important to not to let pain take over your life. We can say to patients. Also, know your limits. Continue to be active in a way that acknowledges your physical limitations. Make a plan about how to manage your pain and don't push yourself to do more than you can handle. And also we will tell the patients to do exercise. Stay healthy with low impact exercise such as stretching, yoga, walking, and swimming. Also, we can say make social connections, call a family member, invite a friend to lunch, or make a date for coffee with a, but you haven't seen in a while. Research shows that people with greater social support are more resilient and experience less depression and anxiety. Ask for help when you need it. Also, that we can say, distract yourself to the patient. When pain flares, find ways to distract your mind from it. Watch a movie, take a walk, engage in a hobby, or visit a museum. Please, present experiences can help you cope with pain. And also that we can say to the patient, don't lose hope. With the right kind of psychological treatments, may people to learn to manage their pain and think of it in a different way. Also, follow prescriptions carefully. If medications are part of your treatment plan, be sure to use them as prescribed by your doctor to avoid possible dangerous side effects. In addition to helping you develop better ways to cope with and manage pain, psychologists can help you develop a routine to stay on track with their treatment. So we can tell the patient to do these things for coping with pain. It's okay. So again, pain is kind of the psychological problem also. All right, so general principles of management of acute and chronic pain. Acute pain and biological adaptive pain is associated with quick onset and short duration. It may be very intense as in post-surgical pain, but the cause and effect relationship is usually apparent and the stimuli are not repeated. So acute and chronic pain can be distinguished by the duration of pain. Several days ago, I showed this slides. Acute pain can become chronic pain if it lasts longer than 3 to 6 months, or the time it would take connective tissue to heal. Chronic pain is persistent pain that becomes part of the patient's daily routine. It is resistant to medical treatment because of neuroplastic changes throughout the central nervous system and in primary nociceptors. So general principles of management of acute pain. The primary aim of acute pain management is to provide treatment that reduces the patient's pain with minimal adverse effects while allowing them to maintain function. So this asterisk say after treating the underlying cause of pain where possible. A secondary aim is to prevent acute pain from progressing to chronic pain. So that is the general principles of the management of acute pain. All right, so acute pain is not so difficult to manage. So difficult thing is a chronic pain. So for the general principles of the management of chronic pain, communicate and listen to the patient and empower them to take a leading role in the management of their condition. Focus on improving function and disability rather than just concentrating on pain outcomes. Ensure that the patient has realistic expectations regarding treatment. Controlling or reducing pain rather than total elimination of pain is usually the goal. And also we can say treat any comorbidities that are frequently associated with chronic pain, for instance, anxiety and depression. Non-pharmacological treatments such as cognitive behavioral therapy and exercise can play a major role in managing the psychological comorbidities of pain. Short-term use of pharmacological treatments, for instance, selective serotonin reuptake inhibitors, SSRI, can also be considered. SSRI is usually used for the depression patients. All right, and also educate the patient that remaining active. Educate the patient that remaining active will be beneficial in managing their pain and encourage them to continue to do activities that bring enjoyment. A positive attitude or outlook can reduce the patient's perception of the pain. Focus on what the patient can do as opposed to what they cannot do. If pharmacological treatment is used to manage pain, always have a plan to taper the dose, even if this is long-term, and avoid increasing avoid increasing doses to chase a pain. So if patient take the medication, any medication for long duration, we need to think about the decreasing the dose of the medication. So again, I show this slides every day. International classification of orofacial pain. So I will follow the this classification, and I will show the management by following this classification. So number one, orofacial pain attributed to disorders of dental barrier and anatomically related structures. So dental pain and non-dental pain. Non-dental pain includes the mucosa, salivary gland, and jawbone. They are dental treatment, daily dental treatment. So you are doing the treatment, this treatment every day, right? So I will not tell you detail of the dental treatment. Number two, myofascial orofacial pain. So what do you do for the myofascial orofacial pain? You can do these things. Number one, explanation of pathological condition. How so you can say that to the patient you have the muscle pain, like shoulder stiffness. So patient is happy after hearing this. And number two, home care, soft diet, teeth apart, mouth opening stretch. Number three, medication, muscle relaxants, tricyclic antidepressants, Chinese herbal medicine, and NSAIDs. Number four, physical therapy, heat, ice, posture training, exercise, mobilization, etc. Number five, occlusal sprint, stabilization sprint. Usually, for the myofascial orofacial pain, we use a stabilization sprint. Also, maybe in India also same, but in Japan, we use a stabilization sprint for the temporomandibular joint pain also. Number six, cognitive behavioral therapy. Number seven, trigger point injection to the muscles. Number seven, transcutaneous electrical nerve stimulation for muscle relaxation. Number nine, botulinum toxin injection for muscle relaxation also. Number 10, acupuncture. It's acupuncture, right? Acupuncture is a Chinese medicine also. So home care, I will tell you home care. So tell the patient eat a soft diet only and don't open mouth wide for a while, not forever, because the anterior pain will decrease. Teeth apart, we say N position, and I will show that picture later. And mouth opening stretch exercise, heat and cold. And so patient can use a hot pack and ice several times. And do deep breathing exercise. So deep breathing exercise, inhale with the nose and exhale with the mouth, and say so, but you don't need to say, you don't give the, patient does not need to say anything, just silently, like this, deep breathing exercise several times. N position posture. So most relaxed jaw position, teeth apart and lips not touching. Patient should maintain this posture throughout the day when you using jaws. So N position, so can you say N? Say N. After say N, your tongue touch the upper floor, right? And a little bit separate upper jaw, upper teeth and lower teeth are not touching, right? And also the lips are a little bit open. Say N, N. So this is the N position posture, and patients should keep this N position as long as they can. Okay, so this is the picture. this is the teeth apart in the position after say N. The patient mouth is like this, and mouth opening stretch. So patient can use a one hands or two hands, either way. So anyway, patient do this mouth opening stretch exercise. And I instructed also the UCLA instructed. I learned at UCLA. So do this stretch for 6 seconds. We can tell the patient count 6, 1, 2, 3, 4, 5, 6, right? And that is a one time, and do 6 times in one session. And also the patient, I ask the patient do this session 3 to 6 sessions every day. Yeah, that is a mouth opening stretch. And also we can, if you can get cold, if you can get a cold spray, you can use a cold spray in the home also. But if in India you cannot, in Japan we cannot get a cold spray, so we ask the patient to use a cold pack. When you buy the cake, you have the cold ice pack, right, with the cake or ice cream. So I ask the patient to use this kind of the cold packs. And also this is the neck muscle exercise. Trapezius muscle stretches like this, and the sternocleidomastoid muscle stretches like this. So you can show the patients. All right, and this is I told to the patient every time. So write the small, what can I say? Small memo, and put the stack sheet or something, seal. You can write it on the seal, right? And you can put anywhere, like pot or in the kitchen or monitor, computer monitor, or remote controller for TV, or the refrigerator or microwave. We can. I told the patient, do write. Do not clench or apart the teeth, or do not touch the teeth. You should write on the memo and put the same many places. But in Japan, most of the patients do not do like this. Do not write down the memo, because they feel that it's shame on the patients, so they don't want to do that. But but patients should remind that they need to do the apart the teeth. It's okay. So medication for the muscle pain, we can prescribe the muscle relaxants, tricyclic antidepressants, topical NSAID cream, Chinese medicine, and in the book they wrote the non-steroidal.
Professor Matsuka, you have muted yourself. So you need to go back to the previous slide.
Okay.
Now it's okay. Thank you.
Sorry, I don't know why. Sorry. So medication for the muscle pain patient, we can use the muscle relaxants, tricyclic antidepressants, topical NSAID cream, Chinese herbal medicine, and non-steroidal anti-inflammatory drugs. And in my clinic, I don't use the non-steroidal anti-inflammatory drugs for the muscle pain patients. But some in the guidebook, American Academy of Orofacial Pain guidebook said, one option is the NSAIDs for the muscle pain patients. So muscle relaxants here, cyclobenzaprine. Muscle relaxants are used to reduce skeletal muscle tone are prescribed in an effort to reduce the supposed increased muscle activity associated with TMD. In TMD patients, cyclobenzaprine was found to be statistically superior to either placebo or clonazepam in reducing joint pain upon awakening, but neither drug had any effect on sleep improvement. A combined protocol utilizing sprint therapy with either placebo or combined muscle relaxant and benzodiazepine demonstrated better pain control with the active medications. So
you're muted again.
it's okay.
It's okay now. I think you were just whatever you were speaking. I interrupted quickly.
Okay. So in United States, I prescribe the cyclobenzaprine, but in Japan, we cannot get the cyclobenzaprine. The cyclobenzaprine is not sold in Japan, but cyclobenzaprine is good. I hope in India you can get it. So antidepressant, tricyclic antidepressants. Antidepressants have been used in chronic pain and have demonstrated pain relief that is not associated with depression relief. Tricyclic antidepressants are beneficial in dosages as low as 10 milligrams in the treatment of tension-type headache and musculoskeletal pain. Amitriptyline has been reported to significantly reduce pain associated with both chronic muscular and TMG dysfunction. No beneficial effects was found with the use of selective serotonin reuptake inhibitors, SSRI, and serotonin noradrenaline reuptake inhibitors, SNRIs, on the prevention of tension-type headache. So do you remember go back. So cyclobenzaprine, you can see the form of this cyclobenzaprine. This is a tricyclic antidepressant, so shape is very similar. So somebody believes that's why tricyclic antidepressant and the cyclobenzaprine have the same effect. And topical NSAIDs, cream, and Chinese medicine. In the clinic, topical NSAIDs and Chinese medicine work well with some patients. However, in some patients, they do not work well. If we will conduct randomized control study, the efficacy will be clear, I think. So topical NSAIDs and Chinese medicine do not show big side effects, of course. So I use for some patients, pregnant patients, polypharmacy patients, and strong drug side effect patients. So for the muscle pain, I prescribe Shakyaku Kanzo To, the Chinese herbal medicine. I think you can get in India. I think, of course, because you have many Chinese. And also non-steroid anti-inflammatory drugs. NSAIDs have been reported as effective for mild to moderate inflammatory conditions and acute postoperative pain. And so let's say, we can say muscle pain is not inflammatory pain. So NSAIDs may have, and also the NSAIDs may have serious side effects, gastrointestinal complications, renal effect, cardiovascular toxicity. So the NSAIDs, and again, in my clinic, I do not use the NSAIDs for the muscle pain. But anyway, do you remember the anti-inflammatory NSAIDs how work? Arachidonic acid has a COX-1, COX-2, and non-selective NSAIDs has a works for the COX-1, COX-2, and COX-2 selective NSAIDs works only COX-2. So they don't have they have COX-2 inhibitor has less side effects, and they go to the work for the prostaglandins. So the NSAIDs reduce the inflammation, pain, hemostasis, protection of gastric mucosa, cell proliferation, etc., etc. All right, physical therapy, like this. Physical therapy helps relieve musculoskeletal pain to restore normal function by altering sensory input. increasing range of motion, reducing inflammation, decreasing coordinating and strengthening muscle activity, and promoting the repair and regeneration of tissue. So physical therapy also works well. All right, so cruiser sprint. Studies focusing on appliance therapy have reported a reduction in orofacial pain and other symptoms associated with TMDs, temporomandibular disorders. However, most studies have been limited by small sample size, short-term outcome, inadequate control groups, and failure to compare appliance therapy with other forms of treatment. Recent systemic reviews concluded that there is a moderate effect of reduction of pain with use of sprint therapy in TMDs. So sprint is work something. And again, for the muscle problem, muscular pain, we use the stabilization sprint, flat type sprint. All right, trigger point injection. So the trigger point injection is the, sorry, I go first. Trigger point is like this. So in the muscle, there is some kind of small bump. So trigger point injection hit this trigger, but this trigger point moves in the muscles. So keep don't hold with 2 fingers not to move and inject. So muscle here, trigger point here, and hit the trigger point. So trigger point injection, use a 1% procaine or lidocaine and no epinephrine. We should use, but in my case, I use with epinephrine sometimes. 3 cc syringe and 1 cc per site, 27 gauge needle, thin needle is better. Injection must tender area. Most heat before injection is better, but in my case, I don't have the moist heat in the clinic. Stretch and cool after injection. If strongly inflamed, we can add a corticosteroid. So after injection, we ask the patient to do the stretch and put the ice pack on, on the muscle. So this is a picture of the trigger point injection. Sorry, this is a 30 years ago picture. Not 30, or 20 years ago picture, and also the at UCLA. So like this. So not good pictures. Good pictures. Okay, so move to the TENS. Transcutaneous electric nerve stimulation. Local electrode placement in painful region. Segmental inhibitory control. Use 30 minutes of low frequency, 2 to 3 Hertz electrical stimulation. Stretch after treatment. Some patients say after this TENS application, some patients said, oh, they feel fine, but pain will come back several days later. And transcutaneous electric nerve stimulation. TENS has been applied clinically in an effort to aid in muscle relaxation, reduce inflammation, and increase blood flow to tissues. Although TENS has more traditionally been used outside of the temporomandibular area, application techniques for temporomandibular and cervical pain have been described. A review of TENS gave equivocal results with a possible short-term benefit, but no difference in outcomes over time. So again, in my clinic also, some patients love the TENS. So they come to clinic every month. After the TENS stimulation, they feel very good. But however, several days later, the pain came back. And so if they love too much, I suggest them to buy this machine, and they do by themselves in the home. Botulinum toxin. Botulinum toxin. Cochrane review concluded that there is an insufficient evidence for botulinum toxin use, including lack of standardized outcome measurements, treatment modalities, and follow-up. Result in a more recent systematic review showed that the pain intensity was significantly reduced in the botulinum toxin A groups compared with the placebo groups are relatively long term of 6 months. Botulinum toxin enter to the synapse or enter to the neuron, and then light heavy chain binds to the vesicles, and light chain go out, and light chain bind to the snare complex. Snare complex is induce the vesicular release, but after the light chain binds to the snare complex, they cannot do the vesicular release, so they cannot release the acetylcholine or some transmitters. So that's why the muscle cannot constrict. That's the botulinum toxin effect. I will tell you the more bond in the research section tomorrow. Acupuncture. Acupuncture. Local needling in sore sites plus several strong neurologic sites in region adds 30 minutes of low frequency 2 to 3 Hz electrical stimulation. Ancient age or long time ago, in China, they used the heat after the needling, but right now they are using the electrical stimulation. Also, we use the electrical stimulation, but in my clinic, I don't do the acupuncture. I will send to the acupuncturist outside in clinic and stretch after treatment. So this is acupuncture, right? It's very thin needle to the Q point. The name is a Q point. The acupuncturist knows where the point. It's not the trigger point. There are different points. All the ancient Chinese medicine has this story. And acupuncture has been used for the treatment of chronic musculoskeletal pain, but the precise mechanism of action is unknown. A systematic review and meta-analysis of acupuncture demonstrated only limited evidence that acupuncture treatment in TMD is more effective than sham acupuncture, while others support that conventional acupuncture is effective. All right, so let's move to the temporomandibular joint pain. So if the patient has temporomandibular joint pain, what do you do? Okay, so again, same. Most point is the same as muscular pain. Explanation of pathological condition, home care, same. Software apart mouth opening stretch, medication, NSAIDs, TCS, Chinese medicine. But for the TMJ pain, NSAIDs works very well. So in my case, first choice is NSAIDs. Physical therapy, heat, ice, posture training, exercise, mobilization, same. Occlusal spring, stabilization, same. So different things. Joint injections are different. So for the temporomandibular joint pain, if pain is severe, I do sometimes joint injection and cognitive behavior therapy and acupuncture. So again, same, same picture. No NSAIDs. So joint pains usually reduce with the NSAIDs. NSAIDs may have, but be careful, NSAIDs may have the serious side effects. But in my case, NSAIDs is the first choice for the joint pain. Topical NSAIDs, cream and Chinese medicine. If patient has a side effects, we cannot give the NSAIDs. So, or many medication already the patient take, we cannot give. So we can give the topical NSAIDs or Chinese medicine. This case, Keishi Kajutsubuto, we can give the Keishi Kajutsubuto. Do you remember the muscle pain? Shakuyaku Kanzoto. So in the TMJ pain, Keishi Kajutsubuto works. So joint injection. If after give the medication and also the some kind of cream and home exercise, physical therapy, still and muscle sprint is fast, but still pain is there. I do sometimes joint injection. So joint injection, in my case, I use the here, I put, my target is here, upper floor, between the skull and the temporal mandibular joint disc. Here the point to inject. So this is the video. So I insert the needle into the joint. It's not so difficult. And hit the floor space, and I suck up, and you can see the some kind of the not clear fluid. Then I do the some flushing the joint. So I'm doing the flushing. You can use the glass syringe. I use the disposable syringe, but glass syringe is easy to see the flushing. And after that, I inject the steroid and steroid with saline or the steroid with the local anesthesia. That is a joint injection. Easy, huh? Not difficult. But when you do to the patient, you need to know where. You need to do exercise somewhere. And management for closed lock. Mobilization with anesthesia and also centesis if it is severe. But also that we can do the opening stretch exercise. And medication and sets also. Physical therapy is good for the closed lock. So physical therapy in the management for closed lock, in my case, physical therapy is a first. Second is a medication. Then joint injection. Then if it doesn't work well, arthrocentesis or arthroscopy. But in my clinic, a patient do not want to have the arthroscopy or arthrocentesis. Too much for them, they think. Okay, all right. So next thing is orofacial pain attributed to lesions or disease of cranial nerves, trigeminal neuralgia, etc. So what do you do for the trigeminal neuralgia patients? Already Dr. Sajjad presented, right? So medication, anti-epileptic medication or tricyclic antidepressants, surgical management, and also the right now nobody do the botulinum toxin injection for the trigeminal neuralgia, but we do some research and I think botulinum toxin works for the trigeminal neuralgia. And carbamazepine is the most effective medication for classic trigeminal neuralgia. The starting dose is 100 milligrams per day, and then the dosage is necessarily increased by 10 milligrams, 100 milligrams every 2 weeks to a maximum of 1,200 milligrams a day in divided dose regimen. The most common side effects include the drowsiness, dizziness, unsteadiness, nausea, and anorexia. Perform a complete blood count and urea and electrolytes. Perform liver function tests at baseline and then every 6 months. After close monitoring over the first 3 months, consider checking CBC and electrolytes every 3 months or twice per day. Twice per year. Sorry, twice per year. Yeah, so carbamazepine is the first choice, but you need to check the liver function and some blood test. And the other medication. Oxcarbazepine, a keto analog of carbamazepine, may be equally effective in the treatment of trigeminal neuralgia. Oxcarbazepine can be begun at 150 milligrams twice daily, increasing the daily dose as tolerated up to 300 to 600 milligrams twice daily, with maximum dose of 2,400 milligrams a day. The side effects profile of oxcarbazepine is less severe than that of the carbamazepine. However, hyponatremia occurs more frequently. Oxcarbazepine is becoming most likely second drug of choice after carbamazepine or first choice. So alternatives to oxcarbazepine include augmenting carbamazepine through the use of baclofen, which has a synergistic effect when co-prescribed with carbamazepine. Following this, the next best alternative is lamotrigine, which has been validated for refractory cases, especially in trigeminal neuralgia due to multiple sclerosis with doses between 100 and 400 milligrams daily. Side effects may include diplopia, dizziness, headache, and gastrointestinal symptoms. Okay, and gabapentin may be an alternative treatment compared with carbamazepine. Gabapentin has a minimum side effects and is better tolerated by older patients. However, there are no randomized control trials. Pregabalin and anti-epileptic drug structure related to gabapentin has shown to be efficacious in the treatment regimen in open label study and according to patient-reported outcomes. So right now, currently, Japanese has not much side effects with carbamazepine, so they cannot tolerate. They cannot be tolerated. So yeah, in Japan, first choice is right now. First choice is maybe pregabalin, not carbamazepine. It's okay. So this is the trigeminal neuralgia patients. So move to the orofacial pain attributed to region of disease of the cranial nerves of same management. Also surgery, microvascular decompression surgery, gamma knife, and medication. Paroxysmal neuropathic pain is a carbamazepine and pregabalin. Persistent neuropathic pain is a pregabalin tricyclic antidepressant. So the surgery, and Dr. Sajjad already gave the lecture. Central surgical techniques, microvascular decompression, as stereotactic radiosurgery, gamma knife surgery, and peripheral surgical techniques, neurectomy, cryotherapy, alcohol injection, etc., etc. And most popular one is the microvascular decompression surgery. The superior cerebral artery, SCA is here, and the anterior inferior cerebral artery, IACA, were found to adhere to and compress the trigeminal nerve. This V is the trigeminal nerve. So the neurosurgeon removed these artery from the trigeminal nerve, actually trigeminal root. Then put the technosil pieces soaked with fibrin glue were placed on the dural surface of the pectoralis bone. Then they wait. After the procedure, SCA transposition was confirmed. In addition, tacosil piece soaked with the fibrin glue was placed on the tentorial surface, and the ICA is the anterior inferior cerebral artery was pressed onto the tacosil on the tentorial surface for 3 minutes. So this is a microvascular decompression surgery. And also Dr. Sajjad already reported precise gamma knife surgery, precisely focused radiation of 40 to 90 gray emitted from 201 photobeam is applied to the trigeminal entry zone in the posterior fossa. Compared with other procedure, onset of pain relief is delayed. Reports of pain relief vary from 61% to 92%, while recurrence rates vary from 10 to 27%. This stage is the most side effects. All right, so move to the migraine, headache. Orofacial pain resembling presentations of primary headache. So diagnosis and management. For the diagnosis and treatment of headache, at this moment, there are limitations of dentists for the management and prescription in Japan. So we cannot prescribe the headache drug. But here, these pictures at USC, University of Southern California, Los Angeles. And my colleague who worked with me at the UCLA as a resident. So we had the same residency program. She moved to the USC and she's a chairman in the USC program chair. Then these guys and ladies are current resident, and they are treating the orofacial pain patients, also migraine patients. I went there before the COVID-19, 2019 or something. I visited there. All right, medications. I hope in India you can you can prescribe these medications for migraine. Acute phase, acetaminophen, non-steroidal anti-inflammatory drugs, ergotamine, triptan, anti-emetics, sedative anesthetics, corticosteroids, prophylactic therapy, lumerizine, valproic acid, propranolol, and dihydroergotamine, the vasoconstrictor or calcium antagonist, these drugs. Also, the non-pharmacotherapy, we have biofeedback, acupuncture, body exercise, massage, diet therapy. So if patient migraine is not severe, we can say just stop the coffee and stop the tobacco smoking. Sometimes they are fine. And orofacial pain migraine, orofacial migraine, educational intervention, lifestyle and behavior modification, trigger avoidance strategy. So some patients, we can do the educate, don't smoke, don't drink, don't drink coffee or don't drink alcohol. And biofeedback relaxation techniques, acupuncture, pharmacological intervention, abortive and symptomatic. Abortive migraine attacks, selective serotonin agonist, triptan. Triptan is very famous for the migraine, and it works very well. Non-selective acetaminophen, aspirin plus caffeine, aspirin, butorphanol, ibuprofen, etc. Prevention of migraine attacks, dipropic sodium valproate, metoprolol, and also botulinum toxin A. All right. And tension type headache. Do you remember tension type headache is like myofascial muscle pain. So medications are same as muscle pain, but acetaminophen, if it works. Prevention, amitriptyline, SNRI, antidepressant. And also the relaxation training by feedback physical therapy. All right, and those cluster headache. And cluster headache. If patient has a cluster headache, we can give the patient sumatriptan or high flow oxygen or zolpidem nasal spray. And for the prophylactic suboccipital steroid injections. And also the paroxysmal hemicrania, if patient has indomethacin, it works very well. All right, so idiopathic orofacial pain, burning mouth syndrome or persistent idiopathic pain, and what the management, burning mouth syndrome, cognitive behavior approaches, topical management using analgesics, anxiolytic, artificial sweeteners, low-level laser therapy, antidepressants, anticonvulsants, and the PIFP, persistent idiopathic facial pain, cognitive behavior therapy, tricyclic antidepressant, SSRI, gabapentin, and pregabalin. And there are many reports that tricyclic antidepressants are effective. Again, in Japan today, drug therapy for idiopathic orofacial pain is out of indication. But the efficacy of tricyclic antidepressants has been reported to be 60 to 75%. Start with an initial dose of 10 to 25 milligram amitriptyline, increase anti-analgesic effect is obtained. Average dose is 60 to 80 milligram, and maximum is 200 to 300 milligram. All right, last one. Psychosocial assessment of patients with orofacial pain. So what do you do if patient comes with the psychosocial problem? with orofacial pain. What do you do? Difficult, very difficult. You can do something. But dealing with patients with somatization symptoms, I showed this slide yesterday. It is important to send the patient to psychiatric doctor. However, many psychiatric doctors do not know the oral diseases. So if the patient complains of oral problems, the psychiatric doctor sends back the patient quickly to you. So again, I showed these slides every day. So somatization symptoms have the comes from the major depressive disorder and also somatoform disorder, other psychiatric disorders. So any mental disorders which manifest as physical symptoms that suggest illness or injury, but which cannot be explained fully by general medical conditions or by the direct effect of substance and are not attributed to another mental disorder, the somatoform disorders I showed yesterday. So again, now the drugs or psychotherapy has a clear effect. Primary care physician, dentists can treat, manage. Regular consult is for every 4 to 6 weeks. Do not get caught by patient complaint itself. All right. Okay, so I run roughly in the psychological part. So I've done this part. So do you have questions?
Thank you very much, sir, for a nice presentation, sir. And in management, you have explained each and every part from the small point to the therapeutical part, pharma part. So, sir, if any questions are there, please, audience, you can ask.
Good morning, sir.
Mm-hmm.
Sir, you discussed about trigger point injection, electrical nerve stimulation, botulinum toxins, and acupuncture. Which one is more effective in reducing the orofacial pain, sir, among these?
So trigger point and botulinum toxin and
Electrical nerve stimulation.
stimulation, you
Yes.
said. Okay. In my experience, the exercise is the most important. So I do not actually I do not compare with the three treatment, right? So if the patient if home exercise or sprint do not work, I will select the botulinum toxin injection or the stimulation or trigger point injection. So I didn't compare with these three management, so I cannot give you the answer.
Okay, sir, but exercise is the thing that you are preferring. Okay, sir, thank you.
Hello, sir.
Yes.
Sir, I have a question.
Mhm.
Why do you recommend moist heat before trigger point injections? Moist heat treatment.
Good questions. So the when you do the trigger point injection, it's better to relax the muscle first. Then, so that's why we use the moist heat. Also, before the original technique, before trigger point injection, we should do the cold spray heat. Because if cold spray hit to the trigger point, the patient do not feel the pain, do not feel the ache with the needle syringe insertion. So originally, when I learned at UCLA, we use the moist heat and relax the patient, and cold spray and inject the trigger point. That is the original one. But in Japan, again, I don't have the moist heat, so just cold and inject and cold again and stretch.
Okay,
It
sir.
works.
Thank you.
Thank you.
So if we use moist heat before trigger point injection, so a trigger point is like we can feel some taut band between the muscles because you said hold it. So is there a possibility that that band is gone when we are, because we are applying heat, so it becomes like soft and now we cannot feel it when we are trying to inject it? Is there a possibility of that?
No, I don't think so. After the moist heat, still band is there.
Okay.
If you have the, I think you have the band here, right? On the shoulder. I think you have, because you're a hard worker, right? So if you feel the band, you put the moist heat here and check the band is gone or not.
Hello, any
Hello.
more questions?
Yes, sir. We have one or two more questions. Wait. I wanted to know, Machika Sensei, one thing. This because you are consistently telling that Chinese medications are very useful and very helpful in Kampo, right? Is the name for TMJ medicine. And for other, there was some other name. There were two medicines you mentioned, a little difficult name to remember. So is there like a generic name in English, or the composition, the major composition of those medicines? Because we have our own traditional medicine, Unani medicine, and Ayurvedic is very popular, but they are never used for maybe never used for controlling pain, this kind of orofacial pain, acute or chronic. So if you will tell us the name, maybe we will try to relate somehow to our traditional medicines, if you know.
Okay, I will check.
Okay, thank you.
Please remind me, mail me.
Okay, sure, I'll mail you, and you just need to maybe just tell the name in Chinese. You said something. So there were two names. Kampo I remember because it sounds like English, but the other two are very difficult name, Chinese name. So
Okay.
if you could send us the name, I will circulate it, and we will try to find if we have some traditional medicine with the similar origin, because sometimes there are overlapping medicine, but because we are not aware of it, we never explore it. So
Dr.
there's-
Saista, I think one medicine we normally suggest, there's a turmeric.
yes, turmeric is turmeric, and what is the other name for it? Sir, Gaurav sir, do you remember?
Turmix, some part is there that is Turmix is a brand name, I think.
Yeah,
I
so
don't remember.
it's like yellow kind of thing. So traditionally,
yeah.
even my grandmother used to give like in a hot milk, you put turmeric, you
Haldi, you're
mix
talking
it.
about haldi, na?
Yes, haldi.
Okay.
So it's yellow color. So and drink it, and you will get rid of the pain. So when we were child, maybe we used to get, but now I don't think it will help because pain is deep inside the mind. So those therapy will not work. Yeah, curcumin, Doctor.
Curcumin, yeah.
Yeah,
Curcumin.
curcumin she wrote, Dr. Karpa Gawali, and she has a she has a question in the chat box, Professor Matsuka. If you could see, please.
Very nice process on mother cake. Cold fermentation is butter is
Okay, so her question is that alternative moist heat and cold fermentation is advisable when we don't use moist heat, and when do we use? She wants to know when should we use moist heat and when should we use cold fermentation. So my question is similar. Like, what should be the protocol? We should use first. We tell patient use cold and hot fermentation, but we never tell how many times cold and how many times hot, and so patient is always confused, and it's a lot of work also if you look from their point of view, that now they have to use warm and then hot and then cold. So what should be the protocol in your point of view with your experience?
in the home exercise, right?
Yes, yeah,
So,
physical therapy, yeah.
We can tell the patient that if a patient feel pain, they can use the heat and cold several times. That's it. So I don't tell the patient how many times and how many hours, how many minutes, but the patient do by themselves until they feel better. And also in Japan, in my patient, they don't do much.
It's same here, because patient compliance is very poor when you tell them a lot of things to do. So one thing I want to know is when we do stretch exercises, shall we recommend using hot fermentation at that time also?
Hot heat?
And when stretch, when we are giving, sometimes I tell when you are stretching, before stretching, use hot, moist heat or cold pack. So shall we tell this or just let them do it anytime wherever they are?
So in the home exercise also, before the stretching exercise, I recommend them to use a moist heat or heat, then stretch with the cold pack. That is a recommendation.
Okay. So we have more question. Somebody?
I want to ask one question. Sir, you talked about the microvascular decompression. So I just want to know how frequently it is being done in your country, and what are the side effects if somebody wants to go for that?
Good questions. So when the patient have the trigeminal neuralgia, we send the neurosurgeon at first, and if the neurosurgeon find the compression, that they do surgery always. But the previous report said that many patients have they have the compression. However, in my clinic, not so many patients have the compression so far.
So point here is because it is an extensive surgical procedure. So for a pain management, do patients agree for that procedure?
What's the question?
For pain management, for this type of pain, do the patient agree for such type of extensive surgery? So that is my question. And how much they are relieved after procedure?
Oh, after the surgery, the patient said completely pain reduced, completely.
Okay.
No pain.
And is there any side effect of this procedure?
They have. This stage, the sensation changed.
Okay. So you will advise we should go for that procedure if it is required?
If you see the trigeminal neuralgia patients or strange pain patient, it's better to send a neurosurgeon at first. If they need, actually, the neurosurgeon can check the brain tumor or the compression or something. So we need to we need to rule out, not to rule out, what's the word? We need to check the patient does not have the brain region or some problems.
Okay, sir. Okay, sir. Thank you, sir.
Thank you.
So there's one question in the chat box. When do we advise MRI for trigeminal neuralgia patients?
When do we advise MRI for trigeminal? Yeah. So again, if patient has maybe sometimes today or tomorrow I will tell. But if patient has a neuralgia pain and neuralgia, it's better to send the MRI or send to the neurosurgeon, neurologist or neurosurgeon, because the neuralgia is sometimes related with the brain tumor or brain infarction or some nerve constriction or something. It's okay?
Yes, sir.
Thank you.
It's okay.
Sir, I have another question.
Yes.
Sir, in your presentation, you said that sometimes you ask the patient to buy the machine for dance therapy. Like, is there any long-term disadvantage of if the patient is doing so frequently, the patient is using this dance therapy so frequently, will there be any long-term disadvantage of this?
So the side effects, long-term side effects, right? So I don't think there is a, actually you can use the TENS, transcutaneous electrical nerve stimulation for long duration. And I do, some patients have long duration, but actually every month, they don't have any side effects. They are okay. Just nerve stimulation, just muscle stimulation. So it's okay.
Okay, sir. Thank you.
Thank you.
I have a question.
Mm-hmm.
Sir, in case of trigeminal neuralgia, sir, do you prescribe peripheral nerve therapies like alcohol injection, cryotherapy, and neurectomies? Because, sir, there is high recurrent rate in such therapies. So, sir, do you prescribe?
Thank you. Thank you. I wrote in the my presentation slides, cryosection or alcohol injection, but usually I don't do that. Also, because there is a severe side effects, right? So first, again, if patient have the trigeminal neuralgia, send to the neurosurgeon and check the brain, and if they are fine, we can give the medication. Still medication doesn't work, we can send to the gamma knife surgery. But in Japan, we don't do the gamma knife surgery much. So maybe medication, only medication is okay currently.
Okay, sir. Thank you, sir.
Thank you.
There's one question in the chat box.
Good question. So physical therapy for the temporomandibular disorder, muscle pain, right? So young adults, usually pain decrease quickly than the older age in my clinic. And so young generation do the gum chewing. So you can ask the young patient, are you chewing gum? And if they say yes, stop the gum chewing. That's it. Very quickly. It's okay. But treatment is same as young and old age. Thank you. Professor Gaurav, you are mute.
So any other question from the participants? So I think this session is over now, and we can proceed to the next lecture.
Yes, sir.
Okay, so the next lecture is management of orofacial pain patients. Again, the same type of topic, but in this case, sir will tell about some cases. So,
All right,
sir, up to you for the next session.
Thank you.
Okay.
So I start the slides.
Okay, sir.
So can you see the slides?
Yes, sir.
Thank you. Management of orofacial pain patients case study. So this is a harbor in Tokushima. Tokushima has a harbor. Anyway, patient. Do you remember the patient number one? Chief complaint. Oh, she's a 39-year-old female patient. Chief complaint: the left lower first molar toothache, and dental caries was found number 19, and also she had a dental treatment, but pain is still there. Do you remember? Occlusal adjustment and occlusal appliance reduce her pain, right? But pain is still there. And medication, medical history, patient has a metal allergy, and the other things okay. So that their pain was number 19, same as initial pain complaint. Tooth clenching or hard food induced the pain. Master muscle palpation induced the pain. headache, shoulder stiffness. Location in the left lower second molar and 1 year, dull pain. Pain scale is a 3 out of 10 and frequent several times a day, several minutes and less than 1 hour. Clenching teeth and hard food aggravate the pain. Do you remember? X-ray is okay, right? So the other examination, tender muscle, master muscle, temporalis posterior berry of digastric trapezius straight mastoid. Jaw movement is okay, no TMJ noise, no TMJ tenderness. So neurological examination, fine. So diagnosis, the primary myofascial orofacial pain and the muscle pain induced the toothache is related to toothache. So diagnosis was a non-odontogenic toothache, myofascial pain referred to tooth. So what's your management plan? Management. Okay, how do you manage? So I showed just previous presentation these things. I selected number 2, home care, exercise, soft diet, teeth apart, mouth opening stretch. After that, pain was reduced a little. And also medications. These medications are options, but she didn't want to take any medications at this moment. And physical therapy, heat, ice, and also actually heat ice, the pain was reduced a little. And also the occlusal splint, I gave her the stabilizer splint, pain was reduced a little. Trigger point injection, we did the lidocaine injection. The pain was reduced completely, but pain came back several hours back, of course, but pain was completely reduced. So I sent to the neurologist because in Japan, dentists cannot do the botulinum toxin injection. So I sent to the neurologist, and the botulinum toxin injection, after the botulinum toxin injection, the pain was reduced completely for half a year in her case. And pain came back a little bit, but she didn't want to do more botulinum toxin injection because she was fine. Pain was a little bit, she has pain, but she's okay, she said. So she didn't go to the botulinum toxin injection again. So this is case number 1. Okay, patient case number 1.5. Between the case number 1 and between case number 1 and 2, I have 1 case here. Post-traumatic trigeminal neuropathic pain. Patient was 60-year-old male. Chief complaint was electric shock pain on the right face. History of present illness. 11 years ago, before the first visit, when, which side? Right lower canine was ground under local anesthesia. There was a burning sensation, he said. After the crown setting, he noticed the pain from the right face to the head and neck. He received endodontic treatment and apical surgery, but they did not improve the pain. The pain was there, still there. Under the diagnosis of trigeminal neuralgia, he received a prescription of phenytoin and gabapentin, but he could not take them due to side effects, drowsiness, dizziness. So he got anti-epileptic medicine already. So what do you do? Treatment, management. What do you do? So I selected the carbamazepine because carbamazepine is the first choice, but he was not prescribed carbamazepine yet. So I studied the carbamazepine 100 milligram and gradually increased. When the dose was increased to 700 milligram, pain was alleviated, but not complete disappearance. So, and also the no lesion was found at the root apex. So when trigeminal nerve root irradiation surgery was performed by neurosurgery with a gamma knife. So I sent to the neurosurgeon and they did the gamma knife surgery. And after that, complete disappearance of pain. So and the carbamazepine was continued after the operation, and it gradually decreased, and the treatment was completed. So this is a traumatic post-traumatic trigeminal neuropathic pain. Was the trauma, the canine grinding, tooth grinding is a problem. So be careful when you grind the teeth, you may have the post-traumatic trigeminal neuropathic pain. All right, so patient number 2. Do you remember this patient? 27-year-old female patient. Chief complaint was a pain in right upper master muscle, which shoots up toward the cheek and forehead. And wisdom tooth extracted 1 year prior to the visit. And after that, pain came. Eating exacerbated her pain. Medical doctor gave her ibuprofen and pain a little better. And she returned 1 month later, indicating the pain was getting worse. And TMD specialist did to the pain, and she became symptom-free. And the patient returned 5 months later, pain came back. And medical doctor recommended that go to the dentist and to make a splint. And she made a splint, but pain still there. Pain came back. Then came to the Orofacial Pain clinic. All right. So pain right cheek area, and the pain is continuous with occasional electric shocks, but varies intensity with that pattern. Pain exacerbated by brushing her teeth, washing her face, pushing on teeth, talking, licking lips, and touching the right face or right palate. The other pain was described as soreness near right TMJ and along the angle of mandible. And so continuous pain, she has one right cheek area, 1 year, soreness, 2 out of intensity was 2 out of 10. And electric shock pain, and 1 year, occasionally electric shocks, but varies intensity with that pattern. Intensity is 8 out of 10, several times a day, several seconds, duration several seconds. And brushing her teeth, washing her face, or touching with the aggravating the pain. So jaw movement is normal, and neurological examination normal, TMJ X-ray normal. So diagnosis, trigeminal neuralgia. But so management, what I did is medication, antiepileptic, TCS, surgical management. So I gave her the gabapentin. So 300 milligram QID means 300 milligram times 4 times. Pain was decreased. But do you remember I said she's young, so I sent to the MRI, and I found a tumor. So 2 centimeter acoustic neuroma in the right cerebral pointing angle. So this is a final diagnosis, trigeminal neuralgia attributed to space occupying region. So I sent the surgeon. So she had the open surgery because the tumor size is big. So after the surgery, she was fine. However, here the etiology of trigeminal neuralgia, one review reported neurovascular compression is around 80% of the trigeminal neuralgia. If patient has trigeminal neuralgia, the neurovascular compression was 80%, around 80%. Multiple sclerosis is 1.7 to 15%. The other tumor is 0.8% to the 11.6%. So her case is this one, tumor. Also, diabetic mellitus or diabetes or herpes simplex virus or allergy induced trigeminal neuralgia, a review reported. Also, Yang reported MRI in the evaluation of trigeminal neuralgia, 51 patients that failed a trial of conservative treatment. So what he did is he gave the medication, conservative treatment medication, and if patient patient pain is still there, what happened? He took the MRI, so he found a cerebral pontine angle tumor 16%, multiple sclerosis 10%, sphenoid or ethmoid sinusitis 4%, meningitis 2%, trigeminal neuritis 2%, and here also vascular contacts or compression 53%. So the most of the etiology of the trigeminal neuralgia is the vascular compression. Here, neurovascular compression 80%. One review reported. Also, that he reported 53%. So here, 164 patients who presented with trigeminal neuralgia as the initial symptoms. So it's not. So this one, the Yang et al. Reported the patient who failed that trial of conservative treatment, but it's not before treatment. 164 patients had a 14% intracranial causative lesion, tumor or multiple sclerosis. 35% had a microvascular compression. Also, the 350 consecutive trigeminal patients, 66% had tumor or vascular malformation of the cerebral pontine angle, right? And also the Yang also reported that intracranial tumor or multiple sclerosis was found from 19 ages, 19 to 83-year-old. Acoustic neuroma and the meningioma frequently in middle age. So if patient had the trigeminal neuralgia, and if patient is under 30 years old, 100% have tumor or multiple sclerosis. So be careful. If you have the young trigeminal neuralgia patient, they have the tumor or multiple sclerosis. And less than 40 years old, 45%. Over 40 years old, 20%. Over 60 years old, 18% patients have tumor or multiple sclerosis. So one out of 5 patients have the tumor or multiple sclerosis, even they are not young, right? So from this data, if you have the trigeminal neuralgia patients, you need to send the MRI or the neurosurgeon to check the brain tumor or multiple sclerosis. Because again, 20% has a tumor or multiple sclerosis. Okay, so management. Trigeminal neuralgia attributed to space occupying lesion. How management? How do you manage surgery? That's it. So in her case, again, I sent the neurosurgeon, and she after the surgery, she was fine. All right. So the other patients, so finish the 2 cases. I have more patients. So I want to show that these patients, the other patients. Patient was 30-year-old female. Chief complaint was upper anterior toothache, trismus, cannot open mouth wide, left TMJ pain, headache. History of present illness. Half a year ago, she hit her face. 30-year-old female hit her face. It's impossible, possible, and was diagnosed with anterior disc displacement without reduction. TMD management did not reduce the pain or symptoms, these symptoms. So MRI showed the, definitely anterior disc displacement without reduction. Difficult to see, but this is a disc. Maybe this is the disc, and this side, right side, difficult to say. But anyway, under this displacement, she had. So she clenches her teeth due to life stress. She thought of divorcing with her husband. She wanted to divorce. She wanted to visit a psychiatrist also, but she was worried her mother would be against it. So if she said she will go to psychiatrist to her mother, the mother said, "Don't go to the psychiatrist. You are not crazy," like this. And mouth opening stretch exercise was not possible when she was mentally weak. So she cannot do the stretch exercise. Tricyclic antidepressant, the spring reduce her symptoms. That's it? Yeah, that's it. So she reduced, so not completely, but tricyclic antidepressant spring is good for her muscle pain. So several years later, she came back to the clinic, and she did divorce with her husband. And after that, she didn't have any pain. She was much fine. Yeah, I saw the different person came, I thought. But she was okay after divorce. So mental stress gave her the depression, and she had a pain. So if you think if a patient has depression, you can ask the several questions. So you can ask the patient like this: please answer the following questions. Have you often felt sick or gloomy over the past month? If say yes, maybe depression. And number two, did you feel interested in things for the past month, or did you feel that you could not enjoy it truly? If the patient say yes, yeah, depression. And now, more question: do you need help for them now? Yes. So we need to send the psychiatrist. It's okay. It's easy questions. Again, somatoform disorders. So depression. Next one is somatoform disorders. So I don't read these things. So I have somatoform disorder patients. Strong complaint of occlusal discomfort. 61-year-old male. I showed 2 days back. Chief complaint of occlusal discomfort or toothache. Over 10 years ago, yesterday maybe, he noticed the occlusal discomfort and toothache in the left mandibular molar. Occasionally, he had toothache in the right mandibular molar. Complaint: the dental occlusion is out of balance. The left side occlusion is low. I have been treated in a dental clinic, but it has not improved. And my face is distorted when I get nervous, and it is due to abnormality of dental occlusion. That is his complaint. 61-year-old male. Present illness. Pain is dull pain. 5 to 8 out of 10. Masticatory muscle had tenderness. Occasionally, the patient was clenching the upper and lower teeth at rest. So this is intraoral pictures. So his occlusion is okay. His occlusion is okay. He had a temporary crown or provisional restoration, the left lower molars. So dental X-ray showed nothing. There was no place where alveolar bone resorption was extremely progressed or with apical regions. So dental X-ray shows it's okay. They're okay. So diagnosis. In addition to psychological problems, occlusal discomfort and toothache due to clenching teeth during daytime and nighttime. Management. I sent the psychiatric department, and psychiatric doctor diagnosed dysmorphic disorder. You know dysmorphic disorder, and prescribed the selective serotonin reuptake inhibitor, kind of the somatoform disorders. Instruction to passive interrupt the contact of the upper and lower teeth at rest and opening mouth stretch. I instructed, and I gave the stabilization sprint. And result: medication from the psychiatry, not touching the teeth, etc., reduced occlusal discomfort, and toothache is okay, reduced. After that, prosthodontic treatment was done. So this after the treatment, so I gave him the crown. So that's it. Somatoform disorder patient. Delusion. What is it? I showed yesterday this slide, right? So I don't tell you much. But delusion is the other psychiatric disorder. The induced the somatization. So delusion patients, inexplicable complaint. Patient was a 54-year-old female. Chief complaint: thread comes out from the mouth, she said. History of present illness: half a year ago, removable dentures, because she doesn't have teeth, right? Removable dentures and the crowns were broken, also anterior crowns broken. And she felt intraoral muscle was cut, she said. You understand? Intraoral muscle was cut, she said. The feeling was not disappeared after making new denture. Her husband watched that she tried to cut the thread with scissors. Do you understand? So her husband found. The patient said, thread comes out from the mouth, right? So real scissors. I have real scissors here. Real scissors she had, and tried to cut the scissors like this. So her husband found. But her husband cannot see the thread, of course. Only she could see the threads. So her husband said to her, "Don't do that. Let's go to the doctor." And the husband brought this patient to the prosthodontic clinic. But it's problem, huh? It's big problem. It's problem to me. She touched the maxillary tooth decay with tongue frequently. So she had a root stump or decays, the anterior teeth, and complained abnormal sensation, I found. So abnormal oral sensation disappeared after maxillary tooth extraction, and cognitive behavior therapy approach, notification of disease name, not sticking to symptoms, association with stress factors, coping acquisition. And after that, she was okay. She became normal patients. So we did the extraction, here, extraction, and also make an upper denture and the lower implant denture. So I gave the implant denture, and because I'm prosthodontist, and 3 years after implant upper structure setting, she was okay. And she didn't want to have the upper implant denture. She said complete removable denture is okay for her. So after that, she's okay. All right. So the other patients, she said, she complained, balloons come from right premolar area, she said. And she showed me that, oh, this is balloon. I couldn't see any balloon. And anyway, she had it's better to make the bridge, right? Of course, her family brought her to the clinic, and her family knows she has a delusion. So of course, she said many times in the home. And so I made the bridge, normal bridge. Sorry, it's a Japanese, the insurance bridge, insurance covered bridge. And she's okay. She said, no balloon come out after the bridge. So maybe she touched this ceramic crown with tongue, and she felt that the balloons there, I think. And also this patient is a normal patient. She said, I'm saying the strange thing. She knows, she knew. And the gingival burning sensation on left molar area. So here, she said, burning sensation. And she needs to drink the water many times because it's very hot. It's not painful. So we cannot do anything, right? So yeah, I didn't do anything. And these two patients said same thing, same complaint. This patient said, upper anterior teeth became soft like rubber during chewing, she said. So when she chewed something, the tooth is like rubber, like this. But when I check, tooth is normal. Nothing problem, no problem. And also these patient said, I know I'm saying the different strange things they said. And so this patient, upper anterior teeth feels like rubber during occlusal contact. So yeah, so when this patient, when contact the teeth is like rubber, she said. So what I did is I gave the local anesthetic and cream gel anesthetic, and I told them to use before eating. And if they use the local cream, anesthetic cream, they said these are okay, but they don't want to have they don't like that smell, and they don't like the taste. So they stopped to use. All right. This is a delusion patient. Complain of occlusal discomfort. So she is around 23 or 25 years old patient. Do you understand? So she said, I asked the dentist to grind all teeth because the tooth contacts gave me occlusal discomfort and toothache. So don't worry, not every dentist do in Japan. And so this patient asked the dentist, grind the teeth, and dentist did the grind all teeth. And also the dentist did the root canal treatment, all teeth. Don't do that. So patient went many dentists, anywhere, Tokyo or Osaka or big cities dentists he visited. Also, he visited many university dental clinic, but nobody could treat, of course. And so he decided to go to United States, even though he couldn't speak English. And he went Los Angeles. Fortunately, Los Angeles, there is a dentist, Japanese-speaking dentist. He found it's good. And, the dentist, the Japanese-speaking dentist said to him, please go to the UCLA, the Dr. Clark. And so he visited the Dr. Clark's clinic. And in the Dr. Clark's clinic, fortunately, Japanese researcher there. So Japanese researcher translated him, the Dr. Clark's words. And that at that time, they took this picture. And Dr. Clark said to him, you should go to the Professor Matsuka in Japan. So he came to my clinic. So what will you do? Nothing, right? Nothing. So so also the family members know he had psychiatric problems. So because he broke some doors or glass window, or he broke many things. And so I talked with him, and finally I could send to the psychiatric doctor, and in psychiatric doctor prescribed the psychiatric medicine. After that, he was fine. He didn't have any pain. He didn't have ocular discomfort. However, he believes, he thought he's not the psychiatric problem. He doesn't have psychiatric problem, he thought. So he stopped the medication, and after that, the problem came back. So he continuously continued to do these things. And I heard that he had a tooth right now, but because he's not living in my city. He lived here. He lived in different city. So I sent my friend and also the psychiatric doctor sent to the psychiatric doctor in his city. So I don't know the current situation, but I heard he had a teeth right now. Okay, so that's it, this presentation. Thank you.
Thank you very much, sir,
Thank you.
for sharing your cases with us.
Mm-hmm.
Any questions from the audience here?
Sir, I have a question.
Mm-hmm.
Sir, is this occlusal dysesthesia same as hypochondria? Sir, hypochondria, which is a disease in which patient feels that he or she has some serious medical illness. So, sir, is it same or is it different than hypochondria?
Occlusal dysesthesia is hypochondria also induce occlusal dysesthesia. Yes. However, the other things also induce occlusal dysesthesia. So not only hypochondria. So occlusal dysesthesia, one of the occlusal dysesthesia is the reason is the hypochondria. It's okay?
Yes, sir. Okay. Thank you,
Thank
sir.
you.
Hello. Good morning, Professor Masuda.
Yes.
I have a question. Do repeated Botox injections develops a resistance with time? Like after 3 months, if we are giving Botox, does it develops resistance with time?
I heard that if you inject second time, usually the Botox effect is bigger than the first time. So let's say the first time it worked for 6 months. Second one had the working for 8 months or 9 months. I heard usually. So the neurosurgeon, not the neurosurgeon, the neurologist said that they can do the several time injection. Thank you.
Sir, I didn't read, I just read the title of one of your case report you recently published in Clinical Case Reports about use of botulinum toxin in toothache, odontogenic problems. So I was wondering, I didn't read it. Maybe it's not available because we can only purchase it. So I thought I'll better share it with you. So I'm just wondering, where did the doctor inject the botulinum toxin? Intraorally around the tooth which was hurting, or like out from outside?
Yeah, that is the case. I showed this one. This one is the, oh, sorry. So I reported this one. I reported this case. In the case report. So I inject the botulinum toxin, not actually neurosurgeon, neurologist inject the master muscles.
Okay, so it was the odontogenic toothache he injected in the muscle.
in the muscle, not odontogenic toothache, the non-odontogenic toothache.
Okay, non-odontogenic toothache. Okay.
You can download. It's a free paper, free open paper.
Nah, I think it's not free.
It's free.
Okay, I'll check.
Not published yet, but after published, it's free. If you want, I can send.
Oh yeah, of course. Okay. It said the research gets said it's already published. Okay, so there is one question in the chat box.
How do we differentiate a patient of oromandibular dyskinesia from dystonia? Ooh, good question. Do you know the dyskinesia and dystonia? What's the difference? Do you know?
I don't know.
I also don't know.
Sorry. So dyskinesia is a movement. Kinesia, right? Dyskinesia is movement. Tonia is a constriction, right? Do you understand? So dyskinesia is like movement. So usually patient do the movement like this. Dystonia is a patient continuously clenching or like this. Spasm or contraction dystonia. Ooh, spasm. Good question again. Have you ever seen the spasm in the patient? Already textbook said spasm, but some researcher or some clinician don't believe the spasm. Of course, the dystonia or dyskinesia, we can see the dyskinesia, but spasm, difficult. So spasm, contraction dystonia. Spasm is like muscle is jaw doesn't move, but muscle just muscle function, muscle action potential action.
So can we feel the taut bands when the spasm is there? Because I find it very difficult, like myalgia, myospasm, myositis. I feel like they're so overlapping terms. Like it's good to read in the book, but when it comes to patient, it's hard to say and differentiate. It's regional, referred, local. So how, like, in any case, the line of treatment will be different or will be the same?
So if patient has a muscle pain, the treatment, myalgia, myofascial pain, originally treatment is the same.
It's like a trigger point injection kind of treatment.
Yes.
Okay.
But basically, myalgia doesn't have the trigger point, basically.
And one more thing I wanted to ask was, you mentioned also that post-trauma anterior disc displacement without reduction. So we see many cases with the internal derangement where the disc is displaced either with reduction or without reduction. So we give a splint as a first line of treatment, and sometimes mouth cannot open, then stretch exercises are recommended. But what should be the, I just want to know that what should be the principle, or what should be the end line we should think, that what should be our aim of outcome from the treatment? Just opening the mouths, because I have a reservation in sending these patients for surgery to replace the disc at its normal position. Sometimes people think that this should be surgically bring back to its normal position, but I feel like it will not be permanent and it's too big treatment for patients. So what do you think? What is your line of action in such cases?
Good question. If patient has a function is okay, that is the goal. So if patient has pain, if pain is reduced, not completely 0, but 10 or 10 out of 100, if patient is okay, function is okay, so that is the goal. So the goal is goal is that the patient can do their own normal life without.
Yeah, most of the time, but sometimes it doesn't work. I remember one time, it's long ago, we referred a case. She has internal derangement with disc perforation. So we thought it's out of our abilities to treat her. So we referred her, and she has a lot of post-trauma, like life trauma. She lost a parents at an early age. So stress was one factor, psychiatry was one factor. Apart from, she had perforation in her disc. So she had a lot of pain which couldn't go. So we referred her to a higher center. And what we got to know was that the dentist at the higher center, because patient was very uncooperative, he just gave her an intermaxillary fixation. It's like he closed the jaw with the IMF for 3 weeks. So I thought it's not the correct, I mean, like I did not like the treatment, but I don't know, then we lost the patient. She didn't come back to us. But do you think it's correct to close? Because if she will move, she will have pain. So just lock the jaw in one position for several weeks to get rid of the pain. So do you think it's a good approach? I don't agree with that.
How about NSAIDs? Did you give?
Yeah, we gave NSAIDs with muscle relaxants also, and a lot of physical therapy. Nothing works for her. Nothing worked for her. It was long ago, and we were also less experienced at that time. I was less experienced at that time, but they were like findings which were definitely telling that her pain is because of those findings. Apart from the fact that she had stress in her life, she had very bad events in her life which were related to her, maybe she was over exaggerating for her pain, but of course they were the symptoms were related to one finding. There was an etiology which should be removed. But this kind of a treatment approach, I thought that it will put her into more trauma, more stress. And I also heard that she came back to emergency for removal of that fixation. So, but then we lost her because she didn't come back to us. Maybe she lost trust in us, in our approach. So what do you think in such kind of cases should be joint injection will give some relief at least for 6 months, and then she will recover? What do you think?
Yeah, also the relaxation, cognitive behavior therapy, also the joint injection also, I think, help. Also, do you have the psychological therapist in the clinic?
Yeah, we have a full psychiatry department in our university hospital, but the stigma of a dentist referring a patient to psychiatry is a little. We need more time for everybody to adapt to that kind of referral. So not many referrals, and then patients' parents don't go to psychiatry, or her relatives were not ready to take her to psychiatry.
One thing is that you can invite the psychologist or psychiatrist in the dental clinic, if you can.
Yeah, we do not have a psychoanalyst or psychiatrist in our hospital. That is one thing we should have. There are many patients who have this problem, and we cannot help them just by ourselves.
No, you can, of course you can.
Just talking doesn't help.
That's talking. Yeah, because listening is the important thing.
Okay, we have a question in the chat box.
But this is the reduction. So if patient reduce mouth opening, right, and the pain doesn't improve after. Yeah, so does not improve after arthrocentesis. It's problem. So before the arthrocentesis, it's better to do the joint injection first. And the difference between arthrocentesis and joint injection, right? Yeah.
Yeah. Yes. Arthrocentesis is joint lavage, right? Most of the time when we do joint lavage, we inject, like you showed your video. You inject something after lavage.
But I do just injection. Arthrocentesis is so you do use a 1 gauge technique two-gauge technique also you have.
I don't do it, but in our oral surgery department, I think they do two gauge, two needles.
Okay, two-gauge. So before arthrocentesis, it's better to do the something before that. So just inject the steroid, the joint injection, or give the NSAIDs or some sprint or something, and also the reduce mouth opening. Oh yeah, reduce also the stretch exercise. And if patient do not go to the procedure, it's okay. It's okay because that is a patient decision. So you can help with the patient without arthrocentesis or joint injection. You can do something. It's okay.
I think it's okay. And one more thing, how often can we repeat the steroid injections? Like how frequently can we give them?
Good question. The steroid can change the shape of the bone. Steroid can melt the bone surface. So the textbook said don't do every 6 months. So if you do inject, you need to wait at least 6 months. But in my case, after I think one-time injection is enough for the in a clinic, for the patient in a clinic.
For one life?
You can do it many times, but
Okay.
I don't recommend you do injection many times.
Does the steroid injections can lead to multiple injections can lead to degenerative joint disease?
Yes, right. So again, the steroid itself change the bony surface. So not degenerative disease, but the joint change will be induced.
Hello, sir.
Okay.
Yes.
Sir, I have this question. The second last patient you showed who was having burning sensation in the left molar area, mandibular molar area. Sir, how did you manage that patient? I mean, it could be because of the teeth were missing in that area. That could be the reason of his feeling of burning sensation there. Did you give him that option that he could replace that teeth, and then did you attempt that?
Good question. So I talked with the patient. So I said we can make the bridge, but she doesn't want, because if she felt if she had a bridge, the more hot around there. She felt that is her feeling. So I didn't give the bridge at that time, and I didn't do anything. And also I don't know. Good question, but I don't know if we have that bridge, her burning sensation decreased or not. I guess maybe not. I guess, but that is my speculation.
Because she has all the teeth except that area, so I thought that it might be because of the absence of teeth there.
I don't know. Sorry.
It's okay, sir.
Thank you.
Professor, I have a question.
Yes.
You were showing in the last lecture that you start with 100 milligram of carbamazepine, and then you go up to 700 or something like that. In my practice, I have observed that these patients, when they come to the OPD, they are in so much pain and distress and anxious that they want something to be, something to get comfortable. So with time, I have started doing like I start with 400 milligram, and then I taper it up or down depending upon the response. The advantage I get is the moment the patient feels there is a relief in the symptoms, even though it may be 10% or 20%, the patient's cycle and the anxiety level decreases. The patient develops more trust in me. That's what I've observed. And sometimes I start with like 400 milligram controlled release and 200 milligram, the normal medication. Sometimes I do 600 right at the start. The only advantage I get is like the patient develops more faith and kind of pain relief. The next time when they visit, I try to titrate it to the proper level. What do you think about this approach? My question is that.
I think it's good. I think it's okay. But when in Japan, in Japan, many people had a business with even with the 100 milligram. So patient cannot tolerate with carbamazepine with only 100 milligram sometimes. So in Japan we start at 100 milligram. So if the patient can take the 400 milligram at first, it's okay. And also in United States, also I learned that also Caucasian also they start 100 milligram. Start point is 100 milligram.
So there are 2 questions in the chat box. Can you just?
Thank you.
Thank you. Can steroid injection cause condylar resorption? Yes, it can. And also this, I've been thinking, carbamazepine. Yeah, I agree. I agree. The oxcarbamazepine less side effects from the carbamazepine. Yeah. So the carbamazepine is the first choice drug, still first choice, but again in Japan we do not select the carbamazepine at first. Sometimes patient because for the side effects.
Okay, one last quick question. So when I was in Tokushima, I saw you started using one mouth opening appliance, which has initial rotation movement and then translation movement, similar to the mandibular movement. So this was for anterior disc displacement without reduction and with reduced mouth opening. So what is the status of using that? We don't have that kind of appliance and I wish we can have. So how can we have it here? One thing. And what is the status like? Are you still, you think in more number of patients after trying, do you think it's very effective and faster than normal stretch? Is it like faster than normal stretch exercises?
Yeah, that one is the opening like this and like sliding, and still I'm using the patient said better than the finger mouth stretch. So that is the machines developed for this reason. Do you understand? And how can I can send you, but you can modify that and
use it.
You can check the patent and
no, the patent itself is good. Like it was on trial basis, right? It was not still in the market. Is it still?
Oh, it's in the market in Japan.
In Japan, so it's like patent issues are there that we cannot.
I think
if we try to, because I think it was very expensive and we cannot sell that in India here. We can advise patient to buy that kind of appliance, but if we need to have a cheaper version for the kind of patients which are coming to our hospital, they are not very rich patients, cannot afford very expensive treatment. So there are, I think, patent issues with that. Appliance still they don't want to sell in India in cheap rates. Okay.
So any other questions from members? Sir, thank you very much. I think there is no more questions from the audience side. So should we proceed for the third session?
Yes, sir, please.
Okay. So our third session is use of various stents and splints for painful temporomandibular disorders. And presenter is Dr. Geeta Rajput. Ma'am completed graduation and post-graduation and postgraduation from the Government Dental College, Indore. Then ma'am did the MBA in hospital administration from Indian Open University. She is currently working as a professor and the postgraduate head of the Department of Prosthodontics. She has been serving this university since 1998 with utmost sincerity. During this period, she has been handling academic and administrative work. Till date, many international and national papers have been published in various journals. So over to you, ma'am. You can join when you start with your presentation.
Thank you, Dr. Gaurav.
Yeah.
Thank you, Dr. Gaurav, for such a elaborated introduction of mine. Am I audible?
Yes, ma'am, you are audible.
Yes.
Ma'am, please share your slides.
My screen is not visible.
No, ma'am.
Now it is visible.
It is not visible, ma'am. Till now
Yes,
it is
visible.
Yes, ma'am.
Okay. Thank you. Just wait. Is it okay now?
Yes, ma'am, it is okay.
So thank you, Dr. Gaurav, for such an elaborated introduction of mine. And from day one, we are learning about the orofacial pain, its causes, perception, transmission, feelings, diagnosis by the different aspect of the orofacial pain. So today we come to the phase that we are planning the treatment of this orofacial pains in different manner. So
Excuse me, ma'am.
Yes.
Ma'am, your slideshow. Please run your slideshow.
Okay. So, so as we all know that temporomandibular joint disorder is one of the common cause of this orofacial pain because it affects the jaw joints, surrounding muscles and ligaments, and it can be the temporomandibular disorders is usually caused by the improper bite, arthritis, wear and tear due to the bruxism, clenching and grinding, and sometimes dislocation of the disc may be there. So usually we feel the symptoms like earache, headache, jaw tenderness, and facial pain. So different kinds of occlusal therapy is applied. So any treatment that alters the patient occlusal condition is called occlusal therapy. So by inserting appliance in between the teeth, we cause the functional jaw position changes. So any change in the functional jaw position will influence the occlusal contact pattern, and this will lead to the improvement in the functional masticatory system. So occlusal therapy may be of two types, reversible or irreversible.
Ma'am, please run your slides here, ma'am.
It is here, it is running.
We can see the only single slide of your introduction.
Now?
No,
second slide.
Still it is same.
Okay. Again, I am.
Now it is there.
So occlusal therapy may be of two types, reversible or irreversible.
Yes, ma'am, continue, please.
Your slide are not changing actually.
Use the button on the lower left side of your slide. Just go down on the lower left. there are arrows on the to change the slides.
New share a bit, say?
No, on the lower left.
Share.
Lower left side, ma'am. Your left side.
Mhm. No, it's not changing here.
Enter button.
No, it's not changing.
Ma'am, ma'am, could you please come out of slide share? Sometimes it happens when, you know, the system is not compatible with Zoom and all. So this is the problem.
I'm
we
out
are
of this. I'm out of this here. I'm not.
Yes, you please share again and don't go to the don't go to the slide share. You just by clicking you can share the slide, because sometimes it creates problem and all. So you just, you know, just select slide which you are talking on, and this is the way we can move on. Otherwise it would be problem. Yes, go to the, please go to the next one. Is it moving?
No, dear, it's not moving. Yes.
No, it's
now
moving.
Okay,
It's
now
moving.
it's moving.
Yeah. Okay. Thanks.
So, ocular therapy may be of two types, reversible or irreversible. So, reversible ocular therapy causes the temporary alteration in the ocular contact and the jaw joint positions. And after discontinuation of the appliance, we can come to the original conditions. And for example, ocular appliances. And in irreversible ocular therapy, the permanent alterations are there, so we can't come to the original conditions. So this irreversible ocular therapy can be done by the rule of thirds, where we can do the selective grinding, crowns, FPDs, and orthodontic therapy. Next is the ocular appliances. An ocular appliance is successfully treatment modality that reduces the symptoms up to 70 to 90% of the cases. It's a removable device. It is made of hard acrylic. It fits over the ocular and the incisor surfaces of the teeth in one arch. It creates the precise ocular contact with or with the teeth in the opposing arch. It may also cause a ocular splint, bite guard, night guard, intraocular appliances, and orthopedic devices and orthodontic appliances. So basically, these stabilization appliances are usually used to stable the condyle in orthopedically stable positions, so we can protect against the abnormal forces and may create the breakdown and tooth wear. The main ultimate aim of this ocular therapy is to gain the optimum ocular conditions that can alter the neuromuscular reflex activity and improvement in the certain muscle pain disorder. Sometimes it is used in the initial stages, but many times it is used as a long-term treatment modality in temporomandibular disorders. So the success of and failure of any kind of appliance, it depends on the selection, fabrication, and adjustment of the appliance and the patient cooperations. At the time of selections, you have to identify the major contributing etiologic factor which causes the disorder. And for this, we need the thorough history and examination and diagnosis of the patients. And we should note that no single appliance is effective in TMDs. Multiple appliances sometimes is required. So, and the fabrication should be done in such a way that it should be compatible with soft and hard tissues. And time to time adjustment is required to achieve the ultimate results. And patient cooperation is very much essential in this case, because appliance is wear by the patients. It's a reversible and non-invasive therapy, but if the patient is not wear it properly, we can't get the proper results. Sometimes it may require the part-time use of the appliance and sometimes the extensive use. In cases where the myogenic pain is there, the part-time use of appliance is sufficient, but in case of the intracapsular disorders, it requires the extensive use of the appliance. So type of ocular appliances are the stabilization appliances. They're also called as the muscle relaxation appliances, and the anterior repositioning appliances. They are also called as the orthopedically repositioning appliances. And other types of ocular devices are the anterior bite planes, posterior bite planes, pivoting appliances, soft or the resilient appliances. So treatment goal of any kind of stabilization appliances is to position the condyles in the rest positions, which is the most superior anterior positions against the posterior slopes of articular eminence. This is called the centric lesion positions. And in these positions, the articular discs are properly interposed. When mandible brought into hinge axis, the closure of the posterior teeth, they contact evenly and simultaneously. Ocular contact or their forces are directed along the long axis of teeth. When mandible moves eccentrically, anterior teeth contact and disocclude posteriors. in the alert feeding positions. Means alert feeding position means when you consume food, you extend your head anteriorly or in the forward directions at about 30-degree angulations. So this is called the alert feeding positions. So in that position, the posterior tooth should be more prominent, and then the anterior teeth contact. The criteria of any stabilization appliances is that it should accurately fit the maxillary teeth. Total stability and retention should be required when the contacting with the mandibular teeth. In centriclation position, all mandibular posterior teeth buccal cusps must be in contact on the flat surface with even forces. And during protrusive movement, mandibular canines only must be in contact with the appliance with even force. In any lateral movement, only mandibular canines should be in contact, and they should exhibit the lateral protrusive contact on the appliance. The mandibular posterior teeth must contact the appliance only in the centriclation positions. No other teeth should come in contact in the centriclation positions. So in the alert feeding positions, the posterior teeth must contact the appliance more prominently than on the anterior teeth, and the ocular surface of the appliance should be flat, as flat as possible, with imprints of the mandibular cusp only, and it should be properly polished. Indication of these stabilization appliances, they are used to treat the muscle pain disorders, to decrease the parafunctional activities that often accompanies with the period of stress, and patient with the temporomandibular disorder relate to the muscles hyperactivity such as bruxism. In patient with the local muscle soreness, patient experience retrodiscitis secondary to trauma, and to also minimize the forces that damage tissues, thus permitting the more efficient healing. So how do we fabricate it? By making the simple engineered impression material. Cast should be poor, free from bubbles. The impression is not inverted because we don't require the large base of the cast. So when a stone is adequately set, the cast is withdrawn from the impression, and it should be free from bubbles and voids. Then the excess stone which is present on the labial side should be trimmed, and then 2 mm thickness of hard clear resin sheet of material is adapted to the cast. So the outline of the appliance is then cut, and they should be cut at the level of your interdental papilla on the buccal and the labial surface of the teeth. And posterior palatal area is cut with a separating disc along with a straight line connecting to the distal aspect of each second molar. Means appliance should be extended till second molar only. The adapted ocular resin appliance is removed from the cast. A lathe machine with a hard rubber wheel can be used to eliminate the excess resin in the palatal area. So the care must be taken that the lingual border should be extended 10 to 12 mm from the gingival border of the teeth and throughout the lingual portion of the arch. A large acrylic bar is used to smooth any rough edges. The labial border of the appliance terminates between the incisal and the middle third of the anterior teeth. Then the small amount of auto-curing acrylic resin is mixed with the depth glass and it thickens. It is added to the ocular surface of the anterior portion of the appliances. So this portion, this anterior, this stop is created in the appliances. This acrylic will act as the anterior stop, which is approximately 4 mm wide and should be extended to the region where a mandibular anterior central incisor will contact. So now question arises, why do we add this anterior stop? So the ocular appliances is then evaluated intraorally, and it should fit the maxillary teeth, offering adequate retention and stability. Lip and tongue movements should not dislodge it, and pressure applied to any portion should not cause tipping or the loosening. If the borders of the appliance have been maintained near the junction of the middle and incisal third of the facial surface of the teeth, adequate retention will exist. So it should be extended till the junction of this incisal and the middle third of the teeth, and this anterior stop should be added to the appliance. So now the question arises, why do we add this? So this anterior stop will help us to get the centriclation positions. How we can get it? When you close the mouth of the patient, the only one central incisor of the lower teeth should be in contact with this stop. So when we ask the patient to close the mouth, or a patient are sitting in the chair with the reclined positions, what happened? The patient closes mouth, and we ask the patient to repeatedly close the mouth, open and close. So what after few closure, you can get the this reproducible positions which patient is getting again and again. So this position is the centriclation position of the patients, and after getting this centriclation positions, we can make it little bit flat. Why it should be flat? So it should not engage it, but the only contact should be there, and it should be make it flat in that way that the anterior teeth should be 3 to 5 mm apart, and posterior teeth should be 1 to 3 mm apart. So after getting this centriclation positions, we go ahead for the further addition of the acrylic resin. this picture shows that why this anterior stop should be flat. So because when you touch the anterior stop with the mandibular teeth, this muscle pull of this anterior this elevator muscle pull will allow the seating of condyle in the condylar fossa in the superior anterior positions, that is central clinching positions, in the base of the posterior slopes of articular eminences. This anterior stop should be flat. It should be perpendicular to the longest of the central incisor. It should not be mesially inclined or should not be distally inclined. If it is distally inclined, then it can cause the posterior shift of the mandible. It can deflect the mandible posteriorly. And if it is mesially inclined, then it can shift your mandible in the anterior direction. So it should be flat. So after getting this centric relation, we have to add the more material in the posterior regions. And the main important thing is that do not change the centric relation positions. So ultimately, your appliance is like that. You should get the on flat surface only this minimum contact of the posterior teeth, which are only in the centric relation. And here the angulation of the acrylic in the 30 to 45 degree angulations, you can get this protrusive marks and the lateral marks, and only minimum contact of the anterior teeth should be there. So in that way, you have to make a stabilization appliance for the patient. So next is the anterior repositioning appliances. It is just used to change the position of the condyle with the cranium. So it is provide to better condyle disc relationship, enhances the adaptation to the retrodiscal tissues. It is indicated in the disc derangement disorders. It is also used in the joint sound. It is used in the intermittent or the chronic locking of the jaws. It is also used in the inflammatory conditions like retrodiscitis. And fabrication is same as like this stabilization appliances till the addition of this anterior stop. So after additional stop is added, then you can locating the anterior position of the this condyle. So relationship of the anterior teeth to the anterior stop in centric relations. However, this position does not reduce the pain or clicking associated with the disc displacement. The patient's mandible protrudes slightly on an opening and closing movement occurs that eliminate the pain clicking. So sometimes we feel this sound in the joints. So when you position your mandible in the anterior directions, this sound disappears. So you can identify this this area as a anterior repositioning appliances, and patient can feel later on comfortable with this. But sometimes the CT is required for this proper location, and this arthroscopy is also required, or sometimes MRI is also required to get the most suitable anterior position of the this condyle. So this marked is labeled as centric relation in the musculoskeletal stable positions, and the condyle is also, and in the second mark you can get this is the anterior position of the condyle. So there are two contact marks now. This one is the centric relation position, and one is the anterior posterior relation, relation of the condyle. So the contact on the anterior stop that eliminate the painful clicking is grooved with a small round burr, and this will help the patient in returning to the desirable mandible position. So you can make it with the burr. So the anterior positioning appliance can cause the mandible to assume a more favorable positions, temporarily creating a more favorable condyle disc relationship. During normal closure, what happened? The mandible anterior teeth contact in the anterior guiding ramp provided by the maxillary appliance. So you in this anterior stops, you place a guiding ramp. So as the mandible closes into the occlusion, the ramp causes it to shift forward into the desired positions. This position eliminates the disc derangement disorders at the desired forward positions of all the teeth contact to maintain the arch stability. Now, criteria for making this anterior repositioning appliances that it should fit accurately to the maxillary teeth. Total stability and retention should be there. In an established forward position, all the mandibular teeth should be in contact with even force. The forward position established by the appliance should eliminate the joint symptoms during opening and closing. And in the retruded jaw range of the movements, the lingual reclusive guiding ramps should contact, and upon closure, direct the mandible into the established forward positions, and it should be smoothly polished. Now, next is the anterior bite plate. So the anterior bite plate is again a hard acrylic appliance worn over the maxillary teeth, providing the contact with only the mandibular anterior teeth. So here only you can use it. It is primarily intended to disengage the posterior teeth and thus eliminate their influence on the function of the masticatory systems. So when you use this anterior plane, all posterior teeth are disapproved. So this anterior bite plane has been used for the treatment of muscle disorders related to the orthopedic instability or an acute change in the occlusal conditions. The parafunctional activities may also be treated with it, but only for the short periods. Some major complication of this is that sometimes the anterior teeth are in contact, but the posterior are disoccluded. So the unopposed posterior teeth have been potential to supra-erect. So if the appliance is worn continuously for several weeks or months, there is a great likelihood that the unopposed mandibular teeth will erupt. So when this occurs and the appliance is removed, the anterior teeth with no longer in contact, and result is a open bite. Next is a posterior bite plane. The posterior bite plane is usually fabricated for the mandibular teeth and consists of areas of hard acrylic located over the posterior teeth and the connected by the cast metal lingual bar. And this treatment goal of the posterior bite plane are to achieve the major alteration in the vertical dimension and the mandibular position. Then pivoting appliances. Pivoting appliances also used of the hard acrylic appliances, and that covers one arch. So there is a single posterior contact. You can see in this diagram, there is single posterior contact of only one contact is present when patient is closing his mouth usually on the second or the second molar region. So this single posterior contact in one quadrant which should be too far posterior as possible. And by this, when you apply this and this force on the below the chin, these teeth and your teeth will come in contact, they come closer, and this area will act as a fulcrum line, and this condyle will go downward. So this can release the intraocular articular pressure and thus unload the articular pressure of the joints. So it is basically this pivoting appliance is used in the cases of the inflammatory conditions like osteoarthritis of the TMJ. And sometimes what happens, there is an acute unilateral dislocation without reductions. This can be used. This treatment can be done by using the unilateral pivot appliances. This is the only appliance which can distract the mandible in the fossa. Next is the soft or the resilient appliances. They are not very much documented in the literature, but they are very helpful in some patients. So they are fabricated with the resilient material that is usually adapted to the maxillary arch, and their treatment goal are to achieve even under simultaneous contact with the opposing teeth. In many instances, this is difficult to achieve the even contact with all the teeth because it is made of the soft material. When you chew it or when you bite it, it is distorted. So it is not used in the most of the patients. So it is most of the time it is indicated as a protective device in the athlete persons, and sometimes high level of clenching or bruxism they can be used. And it's also used in the chronic sinusitis patients. In sinusitis patient, what happens? Sometimes the patients feel sensitivity in the posterior teeth because of the chronic sinusitis inflammation in the sinuses. So at that time you can give the soft appliance to the patient. So the dual laminated ocular appliances are also available. In these appliances, the tooth-borne surface is soft, which is fitted well to this teeth and provide the comfort to the supporting teeth. And the ocular surface is adjustable surface, which can be adjusted up to the required by the patient's treatment. Now, the common considerations of the appliance therapies are: before any permanent therapy, we are doing this ocular therapy, which is non-invasive and reversible. So before any permanent therapy, at least a few features should come in consideration for the appliances. So number one is the alteration of the ocular conditions. So as we all know that our ocular conditions, existing ocular condition, is governed by the neuromuscular control system. So which in turn control the muscle activity. So when you insert the appliance in between your teeth, your existing condition will be eliminated. So when there is any alteration in the existing ocular conditions, it provides a more stable and the optimal conditions. Because existing ocular condition is eliminated, now ultimately your condyle will go into the more stabilized position. So this condition can be achieved. It decreases the muscle activity and symptoms are ultimately decreased. Next is the alteration in the condyle positions. So most appliances provide the musculoskeletally stable position or the structurally compatible and functional position of the condyle. So they ultimately decrease the symptom. Next is the increase in vertical dimensions. So whenever you insert the appliance in between your teeth, there is a definitely increase in the vertical dimensions. So regardless of the treatment goal, whatever treatment you are doing is don't consider, but regardless of the treatment goal, it is temporarily decrease the muscle activity because there is an increase in the vertical dimension. Cognitive awareness, because patient is wearing appliance, and patient who wear the ocular appliance become more aware to their functional and the parafunctional activities. So appliance acts as a constant reminder to them to alter the activities. As awareness increases, factors that contribute to the disorders may ultimately decreases. So sometimes there is a because of the wearing the appliances, the patients feel comfortable. Next is a change in the peripheral input to the CNS. As we all know that sleep-related bruxism appears to have its source in the CNS. So when you insert the appliance between the teeth, what happened? You change the peripheral sensory input to the CNS, and this is causes inhibitory effect to the CNS, and thus decreases the CNS-induced bruxism. And natural musculoskeletal recovery. We know that overused muscles can develop pain. Overuse means their activity is more and rest is less. So when you insert the appliance, the muscles are come in rest, and there is a natural course of this painful muscles conditions is towards the recovery. And the placebo effects. Approximately 40% of patients suffering from the certain TMDs respond favorably to the placebo treatments. As Dr. Matsuka yesterday said that you should have a good relationship with your patients. So, and that time you require nothing. On first day, you should not tell the patient that you are having ocular derangement and you are having such kind of problem because of your ocular disturbance. So don't tell the patient first day. You should make a good contact with the patients. So sometimes the patient develop confidence in the doctor, and then it can decrease the emotional stresses of the patients. So a favorable doctor-patient relationship accompanies by an explanation of the problem and reassurance that the appliance will definitely be effective for you. It can decrease the emotional stresses, and the patient feel relieving in pain. So doctor reputation and confidence in the treatment can also have a great impact on the success of the treatment. Next is regression to the mean. So this is a statistical term that addresses the common fluctuation of the symptom associated with the chronic pain conditions. Some intensity of the pain varies on daily basis. Sometimes it is very marked, and sometimes other days it is more tolerable. If we calculate the this rate of this intensity of the pain in the numerical values, like 0 to 10. If 0 means no pain and 10 means the possible worst possible pain ever. So 0 means no pain means sometimes the patient have pain like 3 or 4, and the other days you have 7, 8 or 9. So when you come to the mean of this all calculations, the mean is like 3. So when patient come to you when he is having severe pain. So when we come to you in the pain scale is 7 or 8. So you give the appliance at that time, you give all your treatment to the patients. So after 2-3 days wearing of this appliance, the pain regress and it come to 3. So now it's the situation become very confusing to the doctor that was the symptom reduction is due to the actual therapeutic effect of the treatment modality, or it was regression to the mean. So at that time you require the long-term studies with the patient, long-term follow-up the patients. So on that basis you can this follow up or the symptoms, and then you can decide the permanent treatment for the patients. So when a patient's symptoms are reduced by ocular appliance therapy, each of these factors must be considered as responsible for the success. In some cases, what happened, the TMJ disorders subside by their own. But if symptoms are persist for longer period of time, TMJ exercises are very helpful in the pain relief. So they have the therapeutic exercises, therapeutic effect on the pain relief, and therapeutic exercise not applied alone, but they are in association with certain these appliances and all. So what is the role of these exercises? They strengthen the jaw muscles, they relax the jaw, they increase the jaw mobility, they reduce the jaw clicking, they promote the jaw healing. And according to the American Academy of Family Physicians, 9 exercises are used to relieve the TMJ pain or to improve the improvement the jaw joint. So this is the first exercise. This is called the relaxed jaw exercise. So in this, you have to keep your tongue on the top of the mouth, and then you drop your jaw slowly and then close. So nothing to do with this exercise. You can repeat it 10 or 15 times per day, and you feel a little bit change in your symptoms. Next is a goldfish exercise. It's a full opening. So what you have to do, you have to put your tongue on the top of your mouth and one finger in front of the ear, that is on the TMJ, and other finger is on the this pointer finger or the middle finger on the chin, and ask the patient to drop the jaw completely and then close. So little bit resistance you feel, but there should be no pain, and you have to do this exercise 6 times in one set, and this one set should be repeated 6 times a day. Then goldfish exercise, partial opening, the same like on the you have to keep one finger on the in front of the ear, that is on the TMJ, and pointer on the middle finger on the this chin, and then ask the patient, and same again the this tongue is on the top of the mouth, and ask the patient to drop the jaw partially and complete it. And same you can do with the other side TMJ, and you feel a little bit resistance, and then you can close your mouth, and there should be no pain during this exercise. So this can be again repeated for 6 times in one set, and one set should be done 6 times a day. Then chin tucks. What you have to do, you have to put back your shoulders and chest up. Then pull your chin in such a way that you should create a double chin. And this position should be hold for 3 times and 3 seconds, and then release. So you do it 10 or 15 times per day. Next is resistance of the this opening of the mouth. So what you have to do in this, you have to put your this thumb on the under the chin and open your jaw slowly, and pushing gently against your chin for resistance. Then hold your jaw for 3 to 6 seconds, and then close your mouth slowly. And second exercise, and this you have to squeeze your chin between your index finger and the thumb, then with one hand, and close your mouth as you place gentle pressure on your chin, and then this will help strengthen your muscles that help you to chew. Then tongue up, simply keep your tongue on the top of the this mouth, and drop your jaw and close your jaw, drop your jaw and close your jaw. So in this way you can feel relaxed. Next is side to side jaw movements, in which in this exercise what you have to do, you have to put a 1/4 inch of object in between your teeth, and then move your jaw side to side. So when you're moving your jaw side to side, and you feel little bit resistance and little bit pain in the joints. So as the exercise becomes easier for you, you have to increase the thickness of this object and do the exercise 6 times a day or 10 times a day. Same is the again put 1 inch of this tongue depressor in between your anterior teeth, and then move your jaw forward and backward positions. You should be in such a position that your anterior teeth should be in front of your upper teeth. So again, you do it in 6 or 10 times, and then in the early conditions, you feel a little bit pain and this in the resistance in the TMJ region, but later on the exercise become easy, and you can increase the thickness of this tongue depressor, and then you can do the exercise 10 or 6 times a day. Next is the muscle conditioning. So the patients with dysfunctional jaw movement can often be trained to avoid these movements simply by watching themselves in a mirror. The patient is encouraged to open on a straight opening pathway. Then stretching exercise can be done and used to regain the normal opening of the mouth. And the patient is instructed to apply stretching force gently and intermittently to the elevator muscles with the fingers. Pain should not be elicited. If the pain is there, you should exercise, stop the exercise completely. Then some resistance exercise also there. The patient is instructed to open against gentle resistance and provide by the fingers, and this will promote the relaxation in the elevator muscles, thus allowing the greater mandibular opening. When eccentric movements is limited, the patient can be asked to move in the eccentric position with gentle resistance from the finger. These exercises are repeated 10 times each session and 6 sessions a day. If they elicit pain, they are discontinued. So when you start your TMJ exercise, you should do them in the slow motion, and they should be start slowly. In the early condition, you can feel pain, but if it is tolerable, gradual improvement may be there. So do the exercise when you are in the relaxed conditions. If the muscles are tensed and you are doing exercises, it may defeat the purpose. So we come to the conclusion that TMD is a complex conditions and a common reason for the emerging emergencies presentation in the dental clinic. Dental practitioners must be competent in recognizing the risk factors to enable a correct and early diagnosis of the TMD and ensure the appropriate management is undertaken to prevent the acute TMDs from the becoming a chronic conditions. Understanding which procedures are likely to increase the risk of this initiating a TMG is most critical for those people who are already predisposed to the condition. Now we know that those who are in a greater risk of developing a TMD are the same individuals in whom the conditions will be present with greater severity and persist as a chronic condition. Once TMD has been established as a chronic condition, the resolution is reversible and is more unlikely. Although ocular appliances may have some diagnostic values, before starting any kind of permanent treatment, the ample evidence must be exist that the treatment must be benefited to the patients. Then only you can start the treatment that because it is a non-invasive and the reversible technique, so you can identify which factor and in which condition we have to give a which kind of appliances. So these are my references. Thank you.
Thank you very much, ma'am, for a nice presentation and sharing your knowledge. I request the participant to ask questions.
Hello, ma'am. I have a question. Can you hear me, ma'am?
Yes.
Ma'am, like in the treatment goals, the fourth goal was in the upright head position, alert feeding position, the posterior teeth contact more heavily than the anterior teeth.
Yes.
Ma'am, I couldn't understand the significance of this point.
Because
yeah.
Because when you are giving the stabilization appliances, you are posterior in center clinching position, you have to get only the minimum contact. So in your posterior teeth should come in minimum contact in the center relation positions. So when you are consuming food or you are in the alert feeding positions, you come forward a little bit. So at that time, the posterior and you are clenching at that time. So when you're clenching at that time, your posterior teeth should be heavily contacted with each other because you are consuming food. So they should be heavily contacted at that time rather than the anterior teeth.
Okay, ma'am. Thank you.
Ma'am, when should we go for anterior repositioning of lens and when should we go for stabilization of lens?
When there is only the myogenous pain is there, you can go for the suppose if we are getting a centric lacing positions. So centric lacing position can get by two methods. One is by the manual manipulations. You can do the bilateral manual manipulation of the mandible, and second is by the anterior stops. So when you are getting, you are doing both the techniques simultaneously, and at that time you can see that if your patient is suffering from any kind of intracapsular disorder, and when you're doing the manual manipulations, patient will feel pain definitely. So if pain is there, it means some kind of intracapsular disorder is there, because patient is not able to achieve the muscular stable position at that time because in centric lacing positions. So if the pain in that position is there, you can definitely go for the anterior repositioning appliance because your patient is unable to achieve that stable position. So you have to give the anterior repositioning appliance to the patients.
Okay, ma'am. Thank you.
Ma'am, I have one question.
Yes.
Ma'am, you have mentioned about the appliances. So what is the role of soft appliances? Is there any role of soft appliances in the treatment of?
Yes, it is already documented that the soft appliances are only used for nighttime. They are used, and they are only used for the bruxism kind of cases. Don't use them for, because it is unable to get the required contact whatever we required, because when I'm giving the stabilization appliances by manual manipulations or by this customized type, so in that case we can give the required amount of contact with each other, but in soft appliances it is not possible. So they are only indicated in the, as an athletic person they are indicated, or they are only indicated in the severe type of bruxism. You can give them in nighttime use, because sometimes appliances require the part-time or the full-time use. So they are use a part-time use, only the nighttime you can use them.
Okay, thank you, ma'am. One more question is there, ma'am. Like for how long we have to give appliance to the patient to wear?
Sometimes you said that this is part-time or long time. Long time is more than year or years. You can give the appliance to the patients, because patients become sometimes if you discontinue the appliance, patient again feel the pain. So with appliance, the patient is comfortable. At that, in that cases, you can give the appliance for longer period of time.
So patient has to use it continuously, or he has to remove while he's
no time. He has to come to you for the time to time adjustment, and you have to find out in which condition this patient is feeling pain, and at that time you have to adjust the appliance, and then you give again ask the patient to use it. And sometimes they are in part time, or if the patients get relief from the symptoms, you can discontinue it. You can remove the appliance from the patient now.
So my question is, patient has to use it when the patient is using it, he has to chew with that appliance, or he has to remove the appliance?
Usually it is not recommended. You have to he has to remove it, but sometimes they said if the patient is able to chew, he can chew. But the literature is recommended that don't use at the time of eating. But you can use it in the alert feeding positions is also recommended. You can use it sometime with the consumption of food and sometimes not.
Okay, ma'am. And you advise those exercises.
Yes.
For how long we have to advise the exercise to the patients?
Till the patient get relief from the symptoms, or sometimes for strengthening the muscles, or such kind of patients which are having myelinated pain frequently, you can go for the different kind of exercises in routine way.
So there is no time limit for that?
No time limit, no time limit for any kind of appliance or any kind of exercises.
Okay, ma'am. Thank you. Any other questions?
Sir, one question is there in the chat box, ma'am. One
Yeah.
question is there in the chat box.
Ma'am, if we use maxillary appliances, won't be exhibited if patient suffering from OSA? Won't mandibular appliances better? Yes, it is recommended that the maxillary appliances is always better than mandibular appliances, because its surface area is more, and whatever contact be required, we can achieve by the using this maxillary appliances. And mandibular only disadvantage of using maxillary appliances is that because it is aesthetically is not patient is not comfortable with this. So in mandibular appliances, aesthetic is not a problem, but where you give this anterior slope, like if you require giving slope, it can not achieve in the mandibular appliances. If we give the anterior repositioning of the appliances, the ramp can only be possible to give in the upper maxillary appliances, not in the mandibular appliances. So
okay, carry on.
So ramp is not possible to give in this kind of appliances. So maxillary appliances are usually required, indicated.
I think that the doctor who wrote the question, she also wants to know in case of obstructive sleep apnea, where we give mandibular prognathic appliance in obstructive sleep apnea. So in those cases, if patient also we are giving appliance for bruxism, like maxillary appliance, so we cannot protrude the mandible in those cases. So what do you recommend in those cases? Like a combination appliance, what do you think will be the best? Because it's really challenging patient with obstructive sleep apnea also, and on top of that, some kind of parafunction is there. So I cannot think of.
there is one study in which what they did with the sleep apnea, they did because you mark 2 marks on the anterior repositioning appliances, they reposition the mandible in the anterior position, and they bind this with the this crepe bandage. So in that also they are using such kind of appliances. I think mandibular appliances in that case is better to give if the patient is suffering from the obstructive sleep apnea. Hello.
Any other
Ma'am.
question?
Hi.
Yes.
I think, ma'am, there are no more questions from the audience side. So, and thank you very much, ma'am, for your nice presentation.
Thank you. Thank you.
Dr. Shaisha, we can proceed for the next session.
Yes, sir, please.
Okay. So now our next presenter is Dr. Hamad Usmani, sir. And the topic is nerve block for orofacial pain management, including radio frequency techniques and neuromodulation. Dr. Hamad is our colleague also, and he is presently working as a professor in Department of Anesthesiology, and his special field of interest is interventional pain management. After requiring training in interventional pain management from AIMS, New Delhi, and through various international courses, he got the opportunity to join as a consultant in charge in pain clinic in JNMC, and since 2005. In pain clinic, he has been engaged in research and management of patients suffering from chronic pain conditions. He has published several research papers in national and international journals on the management of various acute and chronic pain conditions. He is also the chief editor of Indian Journal of Pain and Director Health Medical, and he is the director of Medical Attendance Scheme, AMU Aligarh. So I welcome you, Dr. Hamad.
Thank you, Dr. Gaurav. It's been Dr. Shaista and all the esteemed members of the organizing committee of GIAN. Thank you very much for inviting me here today. And can I share my screen? Give me a minute.
Yes, sir. You can do that.
So, although I know that my background is different from the ones who are engaged in your workshop in this orofacial pain, but still, I would like to highlight my expertise in this field, whether it is nerve block, radio frequency techniques, or neuromodulation, whatever we are engaged here and whatever we are doing here. So it's been a pleasure here to be a part of this project, and to it's always, I feel honored to be associated with you people, with faculty of dental college, dental medicine. So with this, I proceed here, and orofacial pain is being discussed since today morning, and I've heard lectures, a good number of lectures, and they are very good. We know that the pain we felt in the mouth, jaw, and the face, and it's a common reason that the patient is attending your clinics. And the first, first interaction is with you people usually, and patients is usually report to us. Either you refer the patient to us or they come to us once they have attended your clinics, and they always show us that this is the treatment we have received there. I understand that the local disorders, as discussed since today morning, is an important cause, but there are other causes, important neurological, vascular, and even psychogenic causes, which leads to this chronic orofacial pain. So I start with from the one which we commonly see in our clinics, trigeminal neuralgia. And all of you know that this is a unilateral pain. Patient have an electric shock, like it comes in paroxysm of few seconds to 1 or 2 minutes, short duration, and usually along with that you will not find neurological deficit. The latest classification, which is given by the International Headache Society and the WHO and our International Association for Study of Pain, they divided trigeminal neuralgia into primary and secondary types. And primary, the one we call idiopathic, where we do not get any evidence of any neurovascular compression on MRIs. We call it idiopathic. Classical is one where we get on MRIs the neurovascular compression along with morphological changes of the nerve. Sometimes, a patient comes with MRI, he has got trigeminal neuralgia of right side, but the compression on the left side. So that does not, we cannot call it classical. But if there are changes, morphological changes along with neural compression, then we call it classical. And here the role, as discussed today morning, there's a role of surgical intervention also, like microvascular compression. Idiopathic, usually we manage with our interventions. And the secondary, as discussed today, since today morning also, the cerebropontine angle tumors and multiple sclerosis. So this is the latest classification which has been given by the different international organizations, primary and secondary. And one which we have, which I'm going to discuss a little bit detail, is the primary one, especially idiopathic is there, and classical also. So in some cases, they need some surgical decompression, and other cases we can go ahead with the interventions. If you see the male to female ratio, it's more common in females as compared to male. 1:1.5:1. Peak incidence is usually reported at the age of 50 to 70 years. If it is reported earlier, you can suspect some underlying cause. As I said, there could be a secondary trigeminal neuralgia, secondary to a tumor or a multiple sclerosis. 5% cases you will get a history of family disorder. Family history also you will get if you will try to go into detail of the family history. You will get the 5% cases you get a family history. The commonest divisions which are being affected, as you can see, this figure is a V2 and V3, or a combination of the two. V1 involvement is not so common, but the V2 and V3 are commonly involved in trigeminal neuralgia, that is maxillary and mandibular, or sometimes they are a combination of the two. And these are the cases here which we are interested, and we go ahead with our interventions. Now, the common questions that I ask to the patients, and if somebody from the audience would like to participate here in my class, I would love to have two-way interactions here, and that's why I just frame some questions. That these are the common questions that we ask, because most of the diagnosis is primarily clinical. So, are the attacks unilateral or bilateral? What is the nature of pain? So, trigeminal neuralgia is usually unilateral. Nature of pain, I've already explained. It is, it's like a paroxysm, sharp shooting pain. In some phenotypic changes, you will find as a background continuous pain, and on that you will find some paroxysmal pain of sharp shooting type, electric shock like. So there could be two types. It's a pure paroxysmal pain or a background pain, a dull continuous pain, and on that you will find that the paroxysms of this particular nature has come up. So usually, as I said, that these attacks of short durations lasting from 20 seconds to 2 minutes, that is what is written in the books. And you will find a particular dermatomal distribution in this pain. Like if it is V2, then you'll find it's the V2 or V3 or a combination of both. There's no overlapping, which you will find in other, this is how clinically we distinguish it from other facial pain syndromes, from trigeminal neuralgia. And is there any neurological deficit or autonomic symptoms? Can anybody try to answer from the other side? Is there any neurological deficit or autonomic symptoms in patients of trigeminal neuralgia? So usually there is no neurological deficit and no autonomic symptoms. So can anybody tell me if the patient is coming with the unilateral pain with autonomic symptoms, what could be the possible causes here? Or if the patient has got one-sided pain with autonomic symptoms, if someone I would love to. Yeah, that's fantastic. Thank you, ma'am. So in spinopalatine neuralgia, you will have a unilateral symptoms, and I will tell you in short that this ganglion has a close connection with your trigeminal nerve, and sometimes a trigeminal pain. A pain in the distribution of trigeminal nerve with autonomic symptoms. So in that case, it could be an spinopalatine neuralgia, as just ma'am has said. Thank you very much. So this is our clinical algorithm here, that intense paroxysmal unilateral pain, clinical examination, I said the most important thing, but the only diagnostic test which I think which is recommended here to rule out the other causes or to rule out microvascular compression of the neural structures is the MRI scan. So MRI scan, I will say, is one of the basic tests that we recommend in patients who are coming with the neuropathic pain on one half of pain, or it's involving bilateral. So the clinical examination. There are other tests also, nerve conduction studies, but they are not very popular. There are other reflexes also which are being written in the book, which are being elicited. Again, they are not very common, but yes, clinical examination and MRI scan, these are the two important things to make the diagnosis of this particular disorder. And then you have your differential diagnosis. Now, how do we manage here? Initially, we always start with pharmacological therapy, but if the patient does not get a good pain relief on pharmacological treatment, or he has got some intolerable side effects, I will discuss in detail a little bit. Then in that case, we divide the patient into two categories. It's a young patient or it's an elderly patient. In young patients, we avoid neurodestructive procedures usually. So we avoid radiofrequency or alcohol denervations of the nerve. But in elderly patients, as I said, after 50 years, we usually we could proceed with these interventions. I will discuss in detail in short about these technique also, not in detail, sorry. So young patients pharmacological management, or if you can go ahead with some other, I will come to that, some newer non-invasive interventions which are coming up along with pharmacological intervention. So non-invasive interventions now being used and adjunct to the pharmacological. But radiofrequency techniques or neuroablation usually preferred after 50 years of age. It's not moving. So as I've already explained, we have a comprehensive goal-directed plan, multidisciplinary approach, and we have a complete set of treatment options to provide to get the best results in patients who are suffering from this intractable pain of trigeminal neuralgia. So we start with initially with pharmacological management, and you all know the gold standard is carbamazepine. You can start with lower doses with 100 milligram, and you can titrate according to the tolerance of the patient, or you can achieve the maximum output, maximum benefit, therapeutic effect of the drug. Now, patients who are intolerant to carbamazepine, can anybody tell me this picture I have seen? This is the only patient I have in my life. I have seen this patient. Can anybody tell me what is the diagnosis of this patient who is sitting there on the chair? And it's secondary to your pharmacological treatment, only pharmacological treatment.
Allergic.
This is a very classical condition.
No.
Yes, please. Anyone? So can anybody tell me the diagnosis of this condition, which is rare, very rare, but if you have this is a nightmare.
Is the reaction of some drug?
Yes, ma'am. Which drug?
Toxic epidermal necrolysis or
Yeah, you're almost right. You can see toxic epidermal necrolysis or Stevens-Johnson syndrome. So this is the thing. So this is a thing nowadays. A lot of people are doing genotyping and phenotyping of the patient. There's a particular gene which is being seen in such patients, and I've seen in Tata Memorial they are doing a genotyping before giving these drugs, carbamazepine especially, to patients of trigeminal neuralgia. So this is very rare condition, but it's a nightmare. So complete sloughing of your skin and your inside mucosa, and the patient can land up into several serious complications. I've seen only one case in Oxford, my life of 15 years career in pain management. So now on the safer side, you have oxcarbamazepine, and now a good number of studies which are recommending lamotrigine as a cycle 9 treatment, or you can use as as a combination therapy with your these drugs if you have intolerant side effects. And the other drug, as discussed today morning, also gabapentin, phenytoin, baclofen. These are all drugs you can try, but the first three are the commonest one, which is PDQ. So if the patient is not getting good response to your pharmacological treatment, we come to interventional pain management. That is our expertise that we start here. Now we have three choices here. If you want to denervate the ganglion, the commonest one, I do it regularly, radiofrequency lesioning. Glycerol injection was practiced in the past. Before the radiofrequency lesioning, there are certain clinicians, senior clinicians, which are very fond of this technique. And now that there's a balloon decompression has come up again. I'm not practicing it, but I've seen this technique also. So in short, I'll try to highlight a few things. Now in radiofrequency, you have conventional radiofrequency, where the evidence is 2B plus, and you have a pulse radiofrequency, which is although a safer mode, but the evidence is weak, 2B minus. So in most of the cases, my take is to go ahead with the radiofrequency treatment instead of going with the pulse radiofrequency unless we start getting some good results with the modified approaches. So good pain relief, usually I get a relief of 1 to 2 years, sometimes even more also. High degree of sensory deficit, yes, that is there. If you know about this particular condition, anesthesia dolorosa, this is one of the reasons that we do not try this technique in young patients. I think you understand this technique, anesthesia, this particular condition, where the areas for your face is numb, but still you are feeling a lot of burning pain and tingling, on the face, and sometimes patient is not very comfortable in this condition. So this could be a complication of this radiofrequency lesioning. So it's a good technique, effective technique. You need some expertise. There are certain things that we do in our patients to prevent all these complications. And we always check for corneal reflex during the procedure and even after the procedure, because if this reflex is lost, you know what could happen on your this could affect your eyes and it could lead to corneal, superficial corneal abrasions and corneal ulcers. So these are the important things. Glycerol, I do not practice, but I've seen it's not commonly practiced now by the young physicians, because a short duration of effect and high recurrence rate and very high incidence of fibrosis. Because if you do it regularly, you get the fibrosis at the foramen and you will not get good results. The third one, which I've only seen, but I do not do it, is the Gazillion ganglion balloon decompression. Now, in this case, you know, you do not have all these side effects, as I said, like anesthesia dolorosa and all good, and you can do it in young patients also. But there is a very high chances of motor deficit, motor weakness is there, and you know this technique needs lot of expertise in the form of, because once you compress the ganglion, there's certain bradycardia, and sometimes the patient lands up into complete AV block and arrest. So you have to do this technique under anesthesia only, general anesthesia only. Otherwise, you could have some serious issues with the patient. You cannot do it in awake patient as we are doing this technique. Patient is awake, but just some sort of fentanyl and propofol or midazolam. Awake, we call this awake sedation. Patient is awake, he can talk to it, a little bit of sedative and analgesic agent, but here it is not possible. You need a deep sedation or a complete general anesthesia and a control of heart rate, which is important here. So this is the one which we practice commonly in our clinics here. We keep the patient supine. This is a submental view. This is the foramen ovale, and this is how we introduce the needle. This is your maxillary sinus. You can see it, mandible on the other side in between the foramen ovale, and we localize this ovale in the submental view, slightly ipsilateral and submental view, and we introduce this needle directly into the foramen ovale, and this is the final picture before doing the lesioning. This is the clivus. This is your pituitary fossa. So this is how we do a V1, V2. If you go close to it, it becomes V1, then V2, then 3. And it is here where actually this ganglion, trigeminal ganglion lies. So we do a sensory testing to just elicit the paresthesia that this is the area. We ask the patient, is it the same concordant sensation which the patient is having? The second thing, we do a motor testing here. And here we can elicit the mandibular masseter contraction, and then we do aspirate for blood and CSF, and then we start doing listening. We start with lower temperature. Sometimes I start with 55 degree patient, because patient cannot tolerate sometimes 65 or 70. We start with a lower temperature, and then we go ahead with 65, 70, usually up to this one comfortably, and sometimes 75 degrees, up to 60 seconds. So that is how we do the listening. We do 1 or 2 or at least 2 or 3 listening. We do use a needle, radio frequency needle with 5 millimeter active tip, and this is a 22 gauge 10 centimeter needle. And as I said, we always check for corneal reflexes during the procedure as well as after the procedure. This is important. So this is the machine, radio frequency generator, and these are the cable, and these are the needles that we use, usually 22 gauge, 10 centimeter long with 5 millimeter active tip. Some people advocate 2 millimeter active tip, so that you should not have all these deafferentation pain or like anesthesia dolorosa and other side effects. So this is a commonly used practice. Now the second one, balloon decompression. As I said, I have seen this technique. This is a balloon that is inflated and this is compressing the ganglion. But once you compress the ganglion, you get certain bradycardia, and sometimes if the patient is a high risk case, you can get an AV block also. So here it's a thick needle, 14 gauge needle, again 10 centimeter. And we use 4 French Fogarty catheter, and the balloon of the catheter is inflated, which compresses this ganglion. So it's very common to see bradycardia, AV blocks, and sometimes hypertension also. So this is a risky technique, and it's better that you practice this technique under general anesthesia. So this is a comparative study which was conducted by Cheng et al. And this is the radio frequency versus balloon versus glycerol rhizotomy. And they said that in radio frequency, you get a good pain relief up to 97% patients, and even on 50% patients up to 5 years. In balloon compression, it selectively involves only the pain fibers, but it does not. You cannot have an awake operative patient here, and that's why you should give deep anesthesia or general anesthesia to such patients. Now, in glycerol glycolysis, as I said, it's a short duration of efficacy, and you have to repeat the procedure, and that's why it's not being commonly practiced now by the young pain physicians. Now, sometimes, you do not need a neuroablative technique in patients if you have a very isolated involvement or peripheral involvement of the nerves, like involvement of supratrochlear, supraorbital, mental, or infraorbital nerves. And here, what we do, we initially give a diagnostic block with local anesthetic, with or without steroids, and then we can go ahead with a neurolytic agent. And here, my choice is phenol, then alcohol, because phenol is viscous. It stays at the site of the block, while alcohol it would spread out, and you have other involvement of other nerves and other side effects. So I use 8% phenols in such blocks. So these are the peripheral nerve. If you draw a straight line here, then you find supraorbital, supratrochlear is here, supraorbital, infraorbital, and mental nerves. So these are the terminal branches, these three branches. They are in the same axis, if you draw a line. And here I perform these individual nerve blocks, initially with local anesthetic and steroids, followed by phenol 8%, if I get a good relief on diagnostic block. If sometimes patient get a good relief with local anesthetic and steroid block, I do not even do a phenol block. I could repeat if I could repeat the block, if the block would have a good effect up to 1 year, I do not give even phenol. We just give a supraorbital block with local anesthetic and low dose steroid. Similarly, supratrochlear, these are both, all of you know, these are the two terminal branches of the ophthalmic division of the trigeminal nerves. So supratrochlear, supraorbital, and then infraorbital nerve. Now, if you have anesthesia in a localized area, intraoral technique is there, but we usually practice this extraoral technique, infraorbital foramen. As I said, you draw a line, straight line. All these nerves lie in the same axis. And the third one is the mental nerve. Sometimes you have a localized area of paresthesia and pain here, involving the lower jaw, or the lower lips only. In this, it's the involvement of upper lip, infraorbital, and in mental nerve, in the lower lip, and adjacent areas involved. We give a diagnostic block, and if you could have good relief, you can go ahead with the phenol neurolysis. Now, with the opening of new understanding of more and more understanding of the pathophysiological mechanism of these neuropathic pain, and nowadays there's significant investment in R&Ds by different companies. There's a newer technique which are coming up, and this is what we call it. All of these techniques are quite expensive, few techniques, but you can go away. You can stay away from your neuroablative procedures here, and you just place these beads, which we call it the radio frequency beads. These are those electrodes here, and you just place these electrodes, these beads here, like in the supraorbital, infraorbital area, and this is the one which is the battery which could be implanted somewhere by the side, and you can get a good effect. The only disadvantage of that technique is it is quite expensive and invasive. These are the two disadvantages. Now, what is coming up next is, and what will the future of these neuromodulation is these non-invasive devices. And this is the one which we have with us. This is a very basic devices manufactured by MedTech Services, is a StimPod NMS 460. And a special type of waves that come up, they claim that this is a pulse radio frequency signals which comes out from these devices, and you can stimulate the nerves, and you can get a good relief of a good sufficient amount. And the best advantage, you can repeat these procedures. Sometimes initially we repeat it weekly, and then 2 weekly, 4 weekly, and once the patient get good pain relief with your pharmacological. So we do all these procedures along with pharmacological interventions, of course. And if we get once the patient is optimized on therapy, we can stop the cycle. So usually 2 to 4 weeks cycle is there. once a week or twice a week. Patients come to our clinic. Now, this is a new device, transcranial direct current stimulation. Now, this is again a very basic battery operated device. You can see 2 electrodes which you can apply on the forehead of patients. This device is again in phase 3 trials. So, and the results are good. And you know, the waves which comes out, it stimulates your cortical areas, and it basically causes these 2 electrodes. They are placed on the forehead with the head of adhesive. This is a battery which you can easily operate it. And here, what is the role of the currents, impulses, which low dose currents, low dose impulses, which comes out from this device? They actually normalize, you know, the neuroplastic changes, pathological changes that could happen in these nerve fibers, and you can restore the normal balance of these nerve fibers, and you can overcome, you know, the pain conditions, different painful conditions of orofacial pain, including the trigeminal neuralgia. So this device has got a good safety profile, which is being recommended by FDA also, that this is a good, this is a non-invasive device, and there's chances of any side effects is less as compared to invasive devices. But again, all these devices are in the phase 3 trials. In the next few years, we could expect that we could have these devices along with your pharmacological management, and we can avoid these neuroablative procedures, especially in young patients. Now, I'm coming to the second topic. You can stop me once you think a few more slides here. So this is the one I just want to discuss here, and someone has already correctly said that it's a chronic facial pain, you know, in the maxillary arch, root of the nose, is accompanied by autonomic features. You know, sphenopalatine ganglion is the largest parasympathetic ganglion in our body. And once you stimulate this ganglion, because the stimulation of this ganglion, there's lacrimation, rhinorrhea, and you know, all the running nose, stuffiness of the nose, you will find in these features because of the parasympathetic stimulation of this ganglion. So autonomic features in a patients with hemifacial pain, you could suspect sphenopalatine neuralgia. I just want to tell you a few things, as I said in the beginning, about this ganglion, that this ganglion has got a complex neural structure. This has got a complex neural connections. You can see it here. This is the maxillary nerve, and a nerve, and the twig is connecting the nerve with the ganglion. And sometimes you have similar presentation as maxillary nerve neuralgia along with autonomic features. So here you could suspect that it could be a sphenopalatine neuralgia. And if you see it's rich sympathetic and parasympathetic innervations. So this ganglion is not being, the ganglion block of sphenopalatine is not being practiced only for sphenopalatine neuralgia, but for in a variety of conditions. Like you see, it's coming from the seventh cranial nerve nucleus, which is giving the parasympathetic fibers, superior cervical ganglion giving the sympathetic fibers. It's supplying, you know, there's the lacrimal glands, as I said, this is a predominantly parasympathetic ganglion. So it's supplying, and because of the stimulation, it has a release of different, you know, like lacrimation, rhinorrhea, all these parasympathetic overactivity symptoms of. So this, as I said, because of the complex neural structure of this ganglion is blocked, it's being practiced in a variety of conditions along with the sphenopalatine neuralgia, like in chronic migraine headache. Cluster headache is again a type of, you know, autonomic cephalgias, trigeminal autonomic cephalgias, autonomic features, a strong autonomic feature. So if you suspect any orofacial pain with autonomic features, you can give a diagnostic sphenopalatine ganglion block. In trigeminal neuralgia, especially the maxillary one, intractable orofacial pain, cancer pain, you can have, you can try all these ganglion blocks, and sometimes you just do a diagnostic block first. As you can see, here are cotton plunges or a plunger. We use 4% xylocaine in here, and we introduce here in the middle concha, superior middle terminates, and you once you introduce here lies the ganglion. So just if you get a good effect on the diagnostic block, then you can go ahead with the radiofrequency ablation, which is a much safer technique. Is my boss, Dr. Pradeep Jain from Gangaram Hospital. So this radiofrequency denervation of sphenopalatine ganglion is much safer and much effective technique as compared to trigeminal ganglion. And here you get a good. First, you do a diagnostic block. This is mandatory. And after doing a diagnostic block only, you should try a radiofrequency denervation or sphenopalatine ganglion. And as I said, you can try it in a variety of conditions, including chronic cluster headache, migraine, even in cancer pain conditions. Now, just to brush up a few more slides, running short of time, I know. Chronic headache is a common problem, unilateral migraine, bilateral tension type headache. Here, I'm not going to discuss in detail about the pharmacological management. It was already discussed in morning, but once if it is intractable pain and we do not get a good relief, our next line of treatment is the injection of Botox. So we choose a particular group of muscles on the frontal, temporal, and occipital regions, and we give Botox up to 150 to 200 units at a point, 10 to 15 units at a point, and we cover all those major muscles from the front, temporal, and occipital region. And we, in patients of intractable chronic headache or migraine headache, we get good results. And sometimes patients of myofascial pain. Now, again, as I said, we are moving from invasive to non-invasive modalities, and this is a device, Cefali. This is being commonly practiced in the European countries. Once I went there, I found it there. And it's again a non-invasive device. Applied, it sticks to your forehead, and I said that the nerves which are coming out, supraorbital, supratrochlear nerve, the impulses are being transmitted to the trigeminal ganglion. And because, you know, trigeminal ganglion is being said, it's a trigger for all sorts of chronic pain condition in the orofacial region. So it is helpful, again, in certain set of patients. Atypical facial pain. Now, here I just want to highlight one thing. Any patient who is coming with chronic orofacial pain, always do a psychological assessment, psychosocial assessment of these patients. Any patient who is coming orofacial, even a patient of trigeminal neuralgia, you will get a lot of component anxiety and depression in 50% of patients. So if you just manage, I think it's not enough. If you address these issues also, psychological, social issues also, and on the back of associated anxiety and depression, if the patient is having these symptoms, and if you can manage these symptoms with an antidepressant drug, along with your drugs that you're using for the orofacial pain management or the interventions, you can get a good effect. And this is true for all sorts of chronic orofacial, whether it's atypical facial pain. The only difference between atypical facial pain and now here you could have an overlapping of dermatomes. Like in trigeminal neuralgia, you find a particular dermatomal distribution, but here you will find an overlapping dermatomal arrangement, and you have no overlapping of symptoms, and patient will not have a particular dermatomal. The pain is poorly localized, and it is not correlated to the anatomical distribution of the trigeminal. Similarly, this again are not a very common entity, but we do see patients of burning mouth syndrome, patients coming with unremitting oral burning in the absence of any detectable mucosal changes. If you see the mucosa, if you suspect like some lesion is there, or it's secondary to some certain drugs, or it's secondary to some or serious disorder like cancer and all, then you will find there's absolutely no mucosal changes, and it's only a bizarre pattern of pain inconsistent with your neurological and vascular involvement. And again, you will find in these patients on the background, if you take a proper history, detailed history, associated anxiety, depression, and these patients may be cancerophobic also. So what is all you're supposed to do is to reassure the patient that it's nothing serious, and if you can add some anxiolytics and antidepressants, it's good enough, and patient do respond. And you can take a multidisciplinary approach, involve the counselors also, and they can also help. Next one. Again, it's a common one we see in our clinic. Just brushing up the slides. This is a herpes zoster ophthalmicus, involvement of the supraorbital, supratrochlear nerve in patient of herpes zoster, a common one that you see in your patients, and it's usually unilateral. And there's an area of hyperesthesia. Patient will not allow you to touch, even to touch it, this area. Hyperalgesia, allodynia, all these symptoms are there. And if you just look at the patient, you can diagnose the condition. Don't need to touch it. And the management part is, you drug gabapentinoids, anticonvulsants, pregabalin, gabapentinoids, antidepressants, and sometimes you give a block with local anesthetic steroids. But here, never do a neurolysis. It will precipitate the condition. So neurolytic blocks are not recommended in patients coming with herpetic neuralgia or post-herpetic neuralgia. EMD disorders, I think it's already discussed in detail since today morning. I'm not going to touch in detail. The only new therapy that has come up nowadays instead of giving steroids, now we are using PRP injections in TMJ, chronic TMJ disorders. And the literature has also found that the injections of PRP in these areas is much more effective as compared to steroids. Myofascial pain syndromes, again, is discussed in detail. I'm not going to touch it. You will find trigger points here. But again, as I said, always try to find out the underlying causes. Sometimes it might associate anxiety, depression. So this is my last slide. My message is that orofacial pain assessment management has moved from a biomedical to a more comprehensive biopsychosocial. Biological treatment, yes, we are giving to the patient, but along with this, if we can address the psychosocial issues to the patient and we can manage it, we can get a good result. So this is empathy, hope, and ongoing support. This is all these patients need. Thank you very much for your patient care.
Thank you very much, Dr. Hamad, for a nice presentation.
Thank you so much.
I ask the audience to ask some questions if they wish.
Hello, sir. Hello, sir. I have a question, sir.
Please speak aloud. Please speak loudly.
Can you hear me, sir? Now?
Yeah, it's a little better.
Okay. So I wanted to ask you that how can we differentiate between cluster headache patients from the migraine pain?
You know, cluster headache, as I said, it's a part of trigeminal autonomic cephalgias. So in cluster headache, as the word suggests, these headaches come in clusters. You know, sometimes you find some seasonal variations also. But the important thing here, you find autonomic features here. And the first line of therapy is always the pharmacological management, as you do in all sorts of chronic headache, like you start with beta blockers, you know, and then you have antidepressants. But if you think that it's a case of chronic cluster headache, you can always try a diagnostic sphenopalatine ganglion block. So autonomic features, they are predominantly seen in cluster headache, not in migraine patients.
Okay, sir. Thank you.
Sir, which device we can use for neuromodulation?
You know,
we have,
you know, all these devices, you know, no device is being proved 100% effective. These are all the devices which are being, you can say, the phase 3 trials. They are in the clinical trials, but you know, it's a hit and try. Sometimes patients, some patients get a good response with this non-invasive device, which I show you, Stimport. But others said, sir, our pain is exacerbated after using these devices. So it's patient to patient variation is there. Some patients get a good response, others do not get a good response. But the best therapies, you know, the medical therapies and, you know, the interventions, it is sometimes helpful. Again, you have to do a diagnostic block first, followed by a, you know, if you can try a urolysys, you can do it. But so it's basically, yes, please.
So can we give maxillary mandibular block also? As you have said, supratrochlear, infraorbital, and mental.
Yeah.
But yeah, if it is in V2 distribution, so can we give mandibular nerve block?
No, you know, individual nerve blocks we can try, but the one thing is that they're very short lasting. Their effect is very short lasting. And sometimes some patients get a good response, sometimes, because you know, the primary pathology is at the level of trigeminal ganglion. So you have to target the ganglion first. But if the patient is not fit for radio frequency denervation, yes, you can try peripheral nerve block also, maxillary and mandibular.
Okay, thank you.
So there is a question in the chat box: how to differentiate trigeminal neuralgia from myofascial pain dysfunction and migraine?
So you know, trigeminal neuralgia is classical. You know, usually only the two phenotypes which are being seen in trigeminal neuralgia. One is a classical paroxysmal attacks. Second one is a background pain, a low-grade background pain, along with these paroxysmal attacks. So these paroxysmal attacks will definitely be there, which you will not find in patients of myofascial pain syndromes. And what is the other one you said about which type of pain? Myofascial pain and
migraine.
So migraine again, presentation is different. It's a usually a unilateral pain. You will find, if you take a detailed history, some triggering factor which causes migraine. You know, you can try a dose of, you know, for an acute attack, we do use triptans. Still, we use triptans like sumatriptan, rizatriptan. And if the patient responds to these drugs, it means he or she is suffering from a chronic migraine attack. So this is how start clinically, and then you try your medicines. And if you get a good response to triptans, it means patient is suffering from probably a migraine attack, which will not work in patients of myofascial pain.
Sir, excuse me, sir, I have a
If
question.
anyone can add something, yes, please.
Yes, sir. Sir, transcranial direct current stimulation. Sir, can it also help in the treatment of trigeminal neuralgia caused by nerve compression? Sir, if there is nerve compression, then how can direct current stimulation help in the treatment, sir?
As I said, that the two primary neuralgia is idiopathic and nerve compression. So it's not always, I have not seen in a good number of patients. I don't know what the other people and what Professor Matsuga could share it in. Even they said, I was listening to his lecture also, Dr. Matsuga, that in his country also, there are not many people are doing this microvascular decompression, So first, yes, if it is a classical trigeminal neuralgia, the final answer, yes, microvascular decompression. But before going for a surgical intervention, you can always try these non-invasive modalities or a minimally invasive modalities, because you can find a recurrence there also after surgical intervention, which is a major surgical intervention. So why not try all these modalities first as you try a pharmacological management? Along with that, you can try your non-invasive modalities or less invasive modalities, which is not before going for this surgical decompression. But the final answer for classical trigeminal neuralgia, yes, microvascular decompression. If you find changes, morphological changes in the nerve, along with microvascular decompression.
Okay, sir. Thank you, sir. I have one more question. Sir, in case of psychogenic pain, can we use neuromodulation?
Yes, you can use it as an adjunct therapy. But what is required initially is a lot of counseling, reassurance, your antidepressants, and on the background of that, or as an adjunct to that, you can use these neuromodulation techniques.
Okay, sir. Thank you.
Hello, sir. I have a question. Another question.
Yeah, please go ahead.
Sir, what is the role? What is the mechanism of action of Botox in pain relief? I don't get because.
So Botox is a neurotoxin, basically. We inject in the muscle fibers, and if you inject a neurotoxin in the muscle fiber, it will locally paralyze that fiber. So that trigger is there, that spark is there, that gets relieved. That's the basic mechanism. Okay, it's a neurotoxin which denervates, which paralyzes the fibers which have got different receptor bands are there, H and bands. So if the movement of these bands, it gets it gets blocked, and because of this, there's a localized muscular paralysis. I should not use paralysis, but basically the movement of these bands are stopped locally, and you get a local muscle relaxation. Muscle spasm is overcome.
Okay, sir. Thank you.
There's one more question in the chat box. The question is, can endorphins in future make difference in these pain management?
Yes, definitely. Endorphins are always there in our body, and they always release in response to pain, trauma. So definitely we have endogenous endorphins, but yes, with time you can find that you can get the endorphins from outside also, and they could help you. You can inject it, but still it's in a very preliminary stages, in the research, very early stages. So very difficult to say about future at this point of time.
Sir?
Yes, please.
How safe are these neuromodulators, sir? Does it have any harmful effects on the patient?
We always try these therapies once we fail from the primary therapies, or if we do not get a good response to your primary therapy, pharmacological therapy, or if you get too much of side effects with these therapies. As I said, non-invasive devices, they have a good safety profile as compared to invasive devices. And invasive devices, they are the last in the ladder. We only try these devices. They are expensive, they are invasive. If we do not get a good response. If the patient has got severe intractable pain, then only we try these invasive modalities. And every modality has got its own set of side effects, especially the invasive one. And this one is also. But this is the last one in the ladder that we try.
Okay, sir. Thank you.
Okay, Dr. Shaista. Done, Dr. Gaurav?
So I think Dr.
Yes,
Gaurav.
sir. No, I am here. Some problem was there. I was not able to unmute myself.
Oh, fine.
Okay, thank you. Thank you very much, sir.
Thank you.
And I think with this knowledge, I think all the participants get benefited, and I think they were having now a better view about the treatment modalities of trigeminal neuralgia.
Thank you. Thank you, Dr.
Thank you very much, sir. Thank you. So I think we are towards our last lecture, and we have, I can see Dr. Rahul is there. And
yes, sir.
Yes. Hello, Dr. Rahul.
Hello, sir. Good afternoon. Good afternoon.
So this lecture is basically the surgical management of TMJ when we are not getting relief from any other modalities. This is the last resort. So Dr. Rahul is going to speak on this topic. And Dr. Rahul is presently working in AIMS, and he completed his graduation from Panchkula, BRS Dental College, Panchkula, Kurukshetra University, and now he completed his post graduation from AIMS, and his most recent publication is clinical evaluation of Kaban protocol for the treatment of TNJ ankylosis. So he is mainly involved in the surgical part. So over to you, Dr. Yadav.
Thank you. Yeah, good afternoon, everyone. Am I audible?
Yes, you are audible.
Yes, thank you. So I'll be discussing about the surgical management of TMJ disorders. And as you have been discussing that there are a lot of things to be managed when we are suffering from TMJ pain. So the contents of my talk will be introduction. I'll give small introduction and classification, diagnosis and imaging, surgical options, which may include the arthrocentesis, arthroscopy, disc repositioning, and discectomy and total TM joint replacement. So the TMDs are defined as the clinical problems involving the masticatory musculature, temporomandibular joints, and associated structures of the tooth. The clinical features include pain while we are functioning, the mandible, and limitation of mandibular movement is there. Joint sounds are there, and temporomandibular disorders are considered a collection of disorders involving organic, psychological, and psychosocial factors. So coming to the incidence, it is estimated that around 40 to 75% of population displays at least one sign of the disease, and 33% of the population reports at least one symptom of the disease. Age distribution, it occurs mostly in younger age groups. It occurs more in females, and usually single side is involved, but sometimes there will be bilateral involvement. Precipitating factors will be, it occurs in young females, usually in unemployed adults, and psychological factors are also there. Now coming to the classification, Wilkes has divided it into 4 stages. The first is stage 1, which is early. There is a clinical or painless claking is there. No limitation of opening is there, and radiographically there is mild disc displacement with early reduction and normal disc morphology. Stage 2 is early to intermediate, where there is clinically there is a occasional painful clicking and intermittent locking, and radiographically there will be mild to moderate disc displacement with late reduction and mild disc deformities there. Stage 3, there will be intermediate. Clinically there will be joint tenderness, limited in mouth opening, and there will be frequent pain episodes. Radiographically there will be displaced disc, which is non-reducing, and there could be some deformity of the disc, which could be elicited on the MRI. The stage 4 is intermediate. Very clinical, there will be chronic pain, limited mouth opening, And radiographically, there will be shear displacement of the disc without reduction and deformity of disc. There could also be perforation of the disc and degenerative changes in the bone can also be seen. Stage 5 will be in the late stage, there will be variable joint pain, joint crepitus, and radiographically there is known reduction of disc with perforation of disc and attachment of disc and degenerative osseous changes are there. So what are the different modalities to imagine the for the imaging of the TM joint? Usually we go first with the OPG, then either we can go for a MRI or a CT scan. In 40% of the cases, in where the CT has diagnosed the osteoarthritis, it was not detected on the MRI. So if we are suspecting that the patient could have, by clinical examination, we suggest that there could be some osteoarthritic changes, then we should first go in for a CT scan rather than going for a MRI. So it is very important not to focus on minute morphological variations in individuals without any subjective complaints. But it suggests that whenever the patient comes and there are minute changes in the radiograph, but there is no obvious complaint from the patient, so we should not suggest that there could be a temporomandibular problem. There should be some complaint from the patient. And the CBCT and CT is the most reliable imaging method for diagnostic assessment of osteoarthritis of the TM joint. But bone marrow cannot be evaluated as it can be with MRI. So whenever we are seeing a patient, so first we should go in for a CT scan. And if we are suggesting that there could be some problem of the disc, then we'll have to go in for an MRI. The focus should be on evident changes, especially bone destruction, and not on subtle changes in the asymptomatic patients. So the point comes when to do what. Because we know that misdiagnosis is a major problem in patients with TMDs. In particular, the differentiation between intra-articular and extra-articular causes. In case of intra-articular causes, it's crucial that the imaging demonstrate the pathology before any invasive joint treatment is initiated. And to perform both bony and soft tissue diagnostics simultaneously, MRI is the only valid imaging method. So when we are suspecting there could be some soft tissue problem also, it is better to go in for MRI. And when we are suspecting that there's more of crepitus and there could be an osteoarthritic part of it, then first we should go for a CT scan. Same discussing about the role of imaging, the clinical diagnosis of anterior disc displacement without reduction is very reliable when mouth opening is impaired. And in such case, there will be no need for MRI, because when there is a reduced mouth opening, we always, beforehand, we know that the disc is impinging onto the complete movement of the condyle. So it is better to go in for a CBCT. And if one suspects TMJ pathology and OPG findings are equivocal, CBCT should be considered. Now, this was another classification given by Dimitroli. He has classified into 5 categories. It is basically a surgical classification. So we'll be discussing it continuously throughout this presentation. The category 1 is a TMJ where the TMJ is normal. There is no surgery is required, but the patient complains of some kind of pain, which may be of different origin. So the TMJ is normal and no surgery will be required. Category 2 is TMJ's minor changes and all joint components are salvageable. TMJ arthrocentesis or lavage will be required. Category 3 is TMJ is showing moderate changes and most joint components are salvageable, and the TMJ will require some kind of arthroplasty. Category 4 is TMJ showing severe changes and few components are salvageable. So we may need some kind of discectomy, removal of the disc, and condylar surgery. Category 5 is a TMJ showing catastrophic changes and nothing in the joint is salvageable, not even the joint surfaces and the disc. It may have some kind of ankylosis and we may require TMJ resection and reconstruction with alloplastic joint. So as we discussed, in the category 1, there will be normal TMJ. The patient may come clinically with a complaint of TMJ pain and no joint noises, no history of locking or dislocation, full range of jaw movements, and normal chewing. And radiographically, the OPG and the MRI, as we can see over here, it will be, the contour will be absolutely normal. The disc is lying normally at the appropriate position against the eminence. And we can see that there's no changes in the, no pathological changes in the radiographic features. So the diagnosis could be, there could be acute trauma, there could be myofascial pain, there could be some kind of ear pathology, or it could be neuropathic or psychogenic. The treatment is basically based on the medication and splint. Surgery has no role in these types of complaints. Now, what are the different surgical options we have? We must enumerate here the arthrocentesis, arthroscopy, arthrotomy with disc repair or displication, or there is some kind of bilaminar flap repair also. Arthrotomy with discectomy, arthrotomy with discectomy and autologous graft disc replacement. Now there are autogenous replacement and alloplastic replacements. We may sometimes require alloplastic total TMJ replacement. We will keep on discussing it in later slides. Now coming to the category 2, which was dermatology, that clinical presentation, there could be intermittent joint pain, joint clicking, or occasional locking. On radiographically, the OPG shows normal condyle and the MRI shows the disc displacement with reduction of the disc, and condyle is normal contour. As we can see in this picture, that the disc is lying anteriorly and the condyle contour of the condyle and the disc appears almost normal, and it is lying at a proper position where it should be. So the diagnosis is early TMJ internal derangement with joint inflammation and adhesions. Treatment is arthrocentesis and TMJ arthroscopic lab. Now we will discuss arthrocentesis. So the arthrocentesis is basically a lavage of the upper joint compartment, which forces the disc, flexible disc apart from the fossa and washes away the degraded particles and inflammatory components and decrease the intra-articular pressure whenever the joint is inflamed. So in the joint, there is a continuous process to maintain the homeostasis. So whenever both the factors of degradation and building are going on simultaneously. So by doing arthrocentesis, we remove the degradation products or the inflammatory products, and we help the joint to recover. The arthrocentesis has been reported to reduce the joint pain and improve function and reduce clicking. It is most commonly used for anterior disc displacement without reduction disc adhesions. As a palliative treatment, it can also be used as a palliative treatment for acute episodes of degenerative or rheumatoid arthritis. Now there are different approaches for arthrocentesis, which are as superior posterior lateral, which is most common technique, where we put a needle from superiorly and from the pointing superiorly and entering from the posterior part of the joint, and superior anterolateral, the inferior posterolateral and inferior anterolateral, and the endoral approach, where we put it through the ear cavity. Now, the most common approach is, as I told, that superior posterior approach is most commonly used. There is a line which is drawn from the lateral canthus to the most posterior and central point of the tragus, which is also known as Holman-Helsing line. The posterior point of entry is 10 mm in front of this. On this line, we start from the point at the tragus and 10 mm in front of it and 2 mm below. This is the point which is known as A, where we put the first needle. This is the approximate area of maximum concavity of the glenoid fossa, and the distance from the skin to the fossa is around 25 mm. So we can mark it on the needle and we can enter accordingly. Now the anterior point of entry is placed 10 mm further along the cantrotragal line and 10 mm below it. So the point B is here. This is the point B, which is 10 mm from point A and 10 mm below the line. So this marks indicates the highest height of the eminence of the TMJ. Now 2 18-gauge needles are inserted in the anterior and posterior recesses of the upper joint space. Through one needle, ringer lactate 100 to 300 ml is injected into the superior joint space, and the second needle acts as the outflow portal, which allows lavage of the joint cavity. Shinzo et al. Suggested that ringer lactate solution is better tolerated than normal saline. After the procedure, there are some post-operative instructions. Post-operatively, the patient should be given a non-chewing soft diet for a few days. Exercise for range of movement are started immediately and continued for 2 weeks. Analgesics are prescribed as necessary for the pain. Well, because as we have seen that there were just 2 points, A and B, then Laskin suggested that because the access to anterior recess is not necessary, it is easier to merely insert the anterior needle 2 to 3 mm in front of the posterior needle. So when we put a posterior needle at point A, we can again put an anterior needle at point D. and which will be an easier technique while we are doing it. Nirjan et al. Have suggested that the diagnostic value of arthrocentesis is there, and the synovial fluid examination can help diagnose septic arthritis and osteoarthritis. While the contraindication to arthrocentesis are absolute or contraindication infection in the tissues over the site to be punctured, because that may lead to infection leading to the joint cavity. And the relative contraindications are bacteremia, adjacent osteomyelitis, uncontrolled coagulopathy, and malignant tumor. There could be some minor complications which may be temporary facial paralysis, which is by LA. We can just reassure the patient that after around 2 hours, he or she will be fine. And swelling of the neighboring tissues caused by perforation of Linger's lactate solution. We should notice while doing the procedure that we are not extravasating this fluid into the tissues, and almost all of it is coming out. And Nitran reported preauricular infected swelling. So it is always preferable to prescribe antibiotics post-operatively also. And rare complications of endoral hematoma have been reported by Carroll et al. Now, another study was done for comparing single needle versus double needle. That we need to put 2 needles. There is no change in reduction in pain intensity and improvement in maximum mouth opening between the 2 techniques. So what it suggests that we can just put the saline into that closed compartment of the cavity with a single needle, and it will flush itself out. The single puncture arthrocentesis is clinically as efficacious as a double needle arthrocentesis. So do we need to repeat the arthrocentesis? Yeah, it has been seen in this study that repeated arthrocentesis is more successful at reducing the pain and improving maximum mouth opening than a single intervention in the treatment of TM joint disorders. Another technique is arthroscopy. Arthroscopy is a very technique sensitive. There is known as arthro, which means joint, and scopy is to look into the joint. Tagaki was the first to perform the procedure by looking at the cadaver knee, and TMJ arthroscopy was first reported by Onishi in 1975. It allows for visualization of joint directly and allows for simultaneous therapeutic procedure. Internal derangement is the most common indication for arthroscopy. Clinician can look for inflammation, discal changes, degenerative changes in retrodiscal area, and cartilage damage. The limitation of visualization of only superior joint space can be done. As we can see here, we are putting different arthroscope. We are putting the parts of the arthroscope into the joint space, and we can directly examine the joint cavity. But it has a very steep learning curve, and it is very technique sensitive. Some of the procedures can also be performed with the help when we are just removing the degradation products, and we can do some lysis of the disc also. Now, the category 3 is moderate TMJ changes. The clinically patient may have a painful chronic closed lock, recurrent joint swelling, painful recurrent dislocations. Radiographically, we can have OPG may show a normal condyles, but MRI shows a disc displacement without reduction, disc normal or mildly deformed contour and prominent eminence. As we can see over here, the disc is displaced anteriorly and which is not reducing. So diagnosis is moderate TMJ internal derangement, recurrent TMJ dislocation, and treatment will require some kind of TMJ arthroplasty, where we may need a disc plication. We are repositioning the disc, or eminectomy for treatment of TMJ dislocations. So coming to, as we can see in this picture, we can see there is a perforation into the disc. Now coming to arthrotomy with disc repair. It is the oldest surgical procedure. Preauricular and endolar exposure is used. So as you can see in this picture, there is a preauricular incision is taken to expose the joint space, and we just expose the joint by incising the lateral margin of the zygomatic arch. Now, exposure of TMJ capsule and the Wilkie's spreader is applied. This was an old technique, and superior joint space is entered using a needle cartridge. Spreader further expanded, and lateral compartment ligament is divided to expose the inferior joint space. So first we enter the superior joint space, we incise at the lateral margin of the zygomatic arch, and then we find the disc, and then we incise expose the lower inferior joint space. And assessment of disc integrity is made. If no perforation or seriously damaged areas, disc is held firmly against the condyle and retrodiscal tissues are evaluated for amount of tissue to be removed. Anterior and medial release of the disc might be necessary in long-standing cases of anterior disc displacement without reduction. A pie-shaped wedge of the excessive tissue is removed posterior to the disc and closed with 5-O-polygalactine. As we can see in this picture, this is the posterior part of the disc where a wedge of the tissue has been, wedge shape of the tissue has been removed, and we again suture it. Lateral plication is then carried out using a 4-O-polygalactine by closing the disc and the inferior part of the capsule and lateral collateral ligament in a horizontal mattress fashion. After closing the posterior part of the disc, we close the lateral part of the capsule. The purpose is to restore the lateral collateral ligamentous attachment to the condyle. Now, does this repositioning really work? Scientific evidence with regard to effectiveness of TMJ disc repositioning remains scarce. The lack of evidence that disc repositioning is an ineffective procedure points to a future when new TMJ biomarkers will support the technique effectiveness in more rigorously controlled studies. This is a sensitive technique with wide learning curve, and adequate training is important for achieving the best results possible. The TMJ disc repositioning with mighty mini suture anchors. Now introduced by Walford and Mehra, anchors were used to position the disc to the condyle, providing a dynamic stability to the position of the condyle. Now, I am presenting in this case, it is a 19-year-old female with a bilateral anterior disc displacement without reduction. It is restricted to all known surgical options, and visual analog score is of 8. Mouth opening was around 10 mm. So we expose the joint space by preauricular approach, and when we reach the, as we can see, we reach the zygomatic arch, and this is the joint capsule. Now we incise the capsule at the lower border of the zygomatic arch to expose the superior joint space. As we can see here, we enter the superior joint space, and this is the disc below the scissors. You can see. As we can see that whenever the disc is lying anteriorly, we will just free the disc nicely and we'll take it backwards over the condyle. So we free the disc from all parts of it, all wherever the adhesions are there, and then we remove a wedge shape of the posterior part of the disc and suture it. This is a Mitex suture which enters the, it has a metallic part which enters into the condyle. As in this picture, we can see that it enters the condyle to which this suture material is tied. So the disc is basically tied to the condyle over the condyle, and it covers the condyle like this. Here it is very evident that this is the metallic part which goes inside the posterior part of the condyle, and then we take the suture and tie the disc which is anterior displaced with this suture which is fixed to the condyle. Now the disc is nicely covering the head of the condyle, and it is closed with the suture. As we can see in this picture, now the disc is tied. The follow-up after 3 months, the patient has nice mouth opening and nerve functions are fine. Coming to arthrotomy with bilaminar disc repair. It is also a technique where if there is a perforation, the disc can be again repaired. It is used basically for stage 4 and 5 with disc perforation, and it is technically very difficult. Exposure through preauricular endoral approach and incision through lateral collateral ligament is made lateral to the perforation. Now traction sutures are placed at 3 sides. As we can see, we place 3 sutures at different sides around the perforation, and the bridge of tissue between the traction is divided. Then this tissue is divided. So, and the edges of perforation are freshened. Remaining disc cartilage is mobilized as much as possible to achieve maximal condylar coverage. As we see, this is excised and mobilization has been done. Now we bring them together and suture so that this is repaired in 2 laminas. Now coming to category 4 of Dimitroli, it is severe TMJ changes. The clinical presentation is constant joint pain, painful crepitus, mildly limited mouth opening, painful chewing, and radiographic features are early condylar changes CT scan shows mild to moderate condylar degeneration, and MRI shows severely degenerative displaced deformed disc. And early condylar changes shows osteophytes and flattening. As we can see here, the disc is lying anteriorly, which is totally displaced, and there are bony changes into the condyle also. The treatment will include TMJ discectomy plus or minus condyloplasty. Now, coming to arthrotomy with discectomy. In spite of several long-term studies supporting its use, discectomy as a treatment of internal degeneration remains controversial. It is very simple to perform and consists of removing the disc and its fibrocartilage. Arthrotomy with discectomy and autologous graft displacement. There is a little evidence to prove that free graft replacement of disc is superior to no replacement at all. Hypothetically, graft provides a scaffold for ingrowth of tissues from surrounding synovium. Another hope is that it prevents degeneration that follows discectomy, whereas there is no evidence yet to prove this. And dermis and auricular cartilage are most widely used. As we can see in this picture, there is clear evidence of disc perforation, and disc was removed along with shaving of the superior part of the condyle, which had some type of changes into the bony architecture. Now, this is a video showing how we do mitex suturing. We just catch hold of the disc and free it from all the surfaces, and then we put a mitex anchor suture. Now the disc is moving nicely with the condyle while opening the mouth. Now, arthrotomy with discectomy and autologous flap repair. In cases of severely damaged disc, temporal myofascial flap can also be used following discectomy. It is a viable choice for surgeons who are uncomfortable leaving the joint without the disc replacement. And temporal myofascial flap, being a vascular flap, brings blood supply that may be lacking in degenerated joint. There are some things which are alloplastic products also, which are used for disc displacement, disc replacement, which are silicone sheets, elastic implants, Proplast Teflon implants, Goretex, and Proplast fossa implants. Complications of these are the foreign body giant cell reaction and material degeneration with silicone sheets, inflammation and synovitis with elastic, condylar degeneration, erosion of the glenoid fossa with Proplast Teflon, and significant wear of Proplast fossa with condylar resorption. So the question comes, either we do discectomy versus disc replacement. The surgical management of internal degeneration of TMJ should only be considered when known surgical options fail. The discopexy and discoplasty are the initial surgical treatments of choice. Only discs that are highly deformed, perforated, dysfunctional, and lack mobility should be removed. In such cases, replacement is not indicated because none of the current replacement options have data to support superiority over discectomy alone. So we can always perform discectomy without trying to replace the disc. Now, category 5 is catastrophic TMJ changes. The clinical presentation could be intolerable low-grade pain, constant crepitus, locking, malocclusion, unable to chew anything solid. Radiographically, we can see obvious degenerative changes to condyle. MRI disc are destroyed and difficult to see. CT scan may show condylar severely degenerated or ankylosis. As we can see in this, there is a gross ankylosis. That may be because of the trauma, but these are the changes which can be seen in the category 5. Treatment is TMJ resection and total joint replacement. Alloplastic joint replacement. The indication is inflammatory arthritis involving the TMJ not responsive to other modalities of treatment, recurrent fibrosis or bony ankylosis not responsive to another treatment, and failed tissue grafts, failed alloplastic reconstruction, and loss of mandibular height. Now, we can see this case. Here the patient came to us with a complaint of TMJ ankylosis. As we can see, this was pre-op CT scan, where total facial correction was done because the patient was having some kind of deformity of the face, asymmetry of the face, which was corrected with the use of alloplastic TJR, total joint replacement, and other jaw surgeries. This is the pre-op and the post-op of the patient. As we can see, the face has been, the symmetry has been achieved. Here we can see that this is a video showing how we do a joint replacement, preauricular extended approach with the submendibular approach, put a fossa and the mandibular component of the joint. The patient can now function properly, although with joint replacement, there are not lateral excursive movements are not possible. Coming to the conclusion, treatment should begin with conservative management, and in opting for surgical management, each patient needs to be reviewed in case-to-case basis and objectives planned individually. Thank you.
Hello. Thank you, Dr. Rahul, for a nice presentation. And for one thing, I want to congratulate you. Your slides, yeah, the surgical slides are very clear.
Thanks.
Photography part is very good. So, if anyone wants to ask some question, please ask.
Dr. Rahul?
Yes, sir.
I just wanted to know, is there any any experience regarding this PRP injections in temporomandibular joints?
Sir, your voice is not very clear. Dr. Gaurav, can you tell?
No, I also can't hear properly.
It's an injection of PRP, that the temporomandibular joint.
Effectivity of
yes,
PRP injections.
Yeah, he's asking.
Multiple. Yes, sir. Recently, there have been lots of studies done with PRP, and PRP is as a regenerative type of medicine. It is acting nicely in some of the cases, but I am more inclined towards doing the arthrocentesis and let just removing the inflammatory products and let the body heal itself. I am not much into injecting medicines into the joint space. Rather, I go in for operative surgeries, open surgeries.
Okay, thank you.
So, Dr. Rahul, I think we can treat the perforations, disc perforations successfully.
Yes, sir. Yes, sir.
Okay. Because today Dr. Shaista raised question whether we can treat such type of perforation or not.
Yes, sir. If the disc is perforated, it's better. It is non-salvageable. We remove the disc, and nowadays I also put some kind of fat there to just act as a lubricant or a interposition material.
Okay. Thank you very much, Dr. Rahul. I think any other questions from the audience side?
Hello, sir.
Yeah.
Hello.
Yes, you can.
Sir, I have a question. Sir, how far does these surgeries affect the occlusion of the patient? I mean, are there malalignments after the surgeries? Have you seen?
After discectomy, there is no malalignment, but when we do cut the condyle, there is some kind of malalignment is there, and which may require some kind of orthodontic treatment later on.
Okay, sir. Thank you.
So, Dr. Rahul, when after condylectomy, you said some kind of malocclusion is possible.
Yes, sir.
So, how about if you give a pre-surgical stent before doing to maintain the pre-operative occlusion? How about that?
We do give some kind of splint, but whenever we remove it, we require some orthodontic adjustment after the surgery.
Okay, still
Yes,
some kind of derangement is there. Okay, thank you.
Yes, sir.
Hello.
Yes.
Dr. Rahul, my question is that when you attach the this alloplastic material with the disc, how they can use? You insert in between the you can say condyle and the fossa, or you just attach it with the condylar head?
Yes, sir. Whenever we are doing a alloplastic replacement of the joint, we remove everything which is we consider everything is non-salvageable, not the disc, not the condyle, and we shave the some part of the zygomatic arch and eminence also. So we are not leaving any part of the disc there. We put the fossa at the zygomatic arch and put the mandibular component at the ramal part, which is remaining there. Basically, we create a gap of around 1.5 centimeter between the inferior margin of the zygomatic arch and the ramal stump.
Okay, because most of in your studies, most of the literature said that you develop the arthritis or some kind of inflammation later on after using these kind of implants. So I think
initial studies, when these were in developmental stages, there were studies which were saying that there are materials which are leaching materials, but now the implants are quite good and they are having a good prognosis.
Okay, thank you, doctor. Thank you.
Any other questions from the audience? I think there is no more question from the audience. So thank you very much, Dr. Rahul. And now I'll request Dr. R.K. Tiwari sir to present a certificate to Dr. Rahul.
Good afternoon, Dr. Rahul Yadavji.
Thank you, sir. Namaskar.
I, on behalf of Department of Prosthodontics and Yauddin Ahmed Dental College, request you to please accept the certificate of appreciation for your nice presentation under the banner of government initiated academic exchange program. Please accept it.
Thanks a lot, sir. Thanks a lot.
Thank you. Thank you very much.
Okay. Thank you, Dr. Rahul. Thank you, sir.
Thank you, sir. Thanks a lot, sir. Thanks a lot,
Okay.
ma'am. Thank you.
Okay.
Thank you.
So friends, this ends our session for today's session. And I think now I give opportunity to speak to our host, Dr. Nurul. You can take the dice now. Please unmute yourself, Dr. Nurul.
Sorry, yes. But I am saying that we are signing off today. No, we'll join tomorrow at 9 in the morning, and it will go till 12. I think, Dr. Shaishta.
At 12:30.
12:30. Okay, 12:30.
Yes.
It's, I think 11:30 is the program, and then facilitation and the end.
Yes.
The closing.
Lectures will stop. Will be until 11:30, and from 11:30 to 12:30 we have a felicitation of our guest and international speaker, and also a little collaboration discussion for 30 minutes.
Okay.
So
Fair
it's
enough.
until 12:30. Until 30.
Yes. Okay.
Thank you very much, Dr.
Chalo. Okay. Thanks a lot.
Okay.
Thank you, everyone.
Thank you.
Yeah.